Hi everyone, a very warm welcome to all of you guys in the discussion of radiology, where we are going to learn about all the important questions that has been asked in your previous examination. This is going to be a very quick, crisp content which you will be revising just before your examination. I would like to give some information, extra information, just to make you understand in your clinical practice also, right? And we will be going very rapidly through this particular subject, right? This is what is going to be the funda for the class, right? What is going to be the scheme, the topics we are going to start. We will learn about the basic of radiology first, then we will discuss about the gastrointestinal system. What are the things we are having in the GIT? You can have what Zenker's diverticulum, like you are having what bird beak appearance. We will be having multiple atrasias, right? So this is how we are going to understand in the format of a story. We are going to learn about the GIT system, then we will discuss about the hepatobiliary system, where we are going to see the liver and bile duct, how they are going to come, right? And then we are going to learn about the genitourinary system, where we are going to look about the kidneys, ureter, urethra. Okay, then we will discuss about the cardiovascular system, different pathologies of cardiology. We are going to see how we are going to see those things under CT scan or your ultrasound, how we are going to understand all those things, right? Your musculoskeletal system, obviously, right? We are also going to learn about the respiratory system, your CNS tumors and all those things, right? And in ENT, what are the radiological identification that we are using? This is also we are going to learn, and we will end up with the miscellaneous topics, right? So this is going to be the scheme of class. The most important thing I would like to focus is going to be the basics of your radiology. If you understand the basic, if you know the anatomy, you can easily derive things for yourself, right? So let's begin with the first thing. The first thing we have got is going to be the radiation. What is radiation? What is radiology and what is this radiation? Okay, so study, radiology. Logi means study, radio means the study of radiations. And what are the types of radiations we can have? We can have two types of radiation. Radiation is nothing but a form of energy, right? We have got ionizing radiation, we have got non-ionizing radiation, we have got ionizing as well as non-ionizing radiation. In ionizing radiation, we have got what? Photons, and we have got what? Particles, right? We have got photons and particles, and remember, we are going to use most commonly, that is going to be the photons, right? We have got x-rays and gamma rays. These are going to be the ionizing radiation. Ionizing radiation. Non-ionizing radiations are going to be those rays which are not going to penetrate the body, right? For example, we have got what? Visible light. We have got what? UV rays. We have got sound waves, radio waves, infrared, MRI, USG, phototherapy. All these things are going to be what? These things are going to be non-ionizing radiation. Whereas ionizing radiation is going to penetrate the body, and that is why we are using what? Most common ionizing radiation that we are using is going to be your X-rays. X-ray can be used for the radiograph, that is the X-ray we are taking. It is the same rays we are going to use in the CT scan also, in the DEXA scan also, for the bone identification, right? Barium studies, we have seen barium meal, barium follow through. We are going to understand what are these barium studies, right? We are going to learn about hysterosalpingography, right? We are going to see the fallopian tubes. Fluoroscopy, which is going to be a 3D, like you can say, live X-ray. Fluoroscope is known as live X-ray, right? We can also do with the help of X-rays. We can do IVP, we can do MCU, we can do RGU. These are the things I'm going to make you understand what is this, right? So all these things are going to utilize what? X-rays. Whereas what about gamma rays? Beta, gamma rays are going to be nuclear scans. We have got your PET scan, right? Positron emission tomography, PET CT we are doing, right? We are also doing what? Bone scans. We are doing HIDA scans, right? We are doing DMSA. All these scans are going to utilize which rays? Very good. These are going to utilize what? Gamma rays, right? Then we have got alpha and beta particles. These particles we are not using very commonly in the identification of like things. Like beta rays will be emitted by radioisotope that we are giving, iodine radioisotope that we are using to destroy the gland. This is going to cause what? This is going to cause release of radioisotopes, right? So this is going to release what? Beta rays. Now we have got some scientists. What are the important scientists who has discovered important things we are having? The first one, also known as the father of radiology, he is nothing but your W.C. Roentgen. W.C. Roentgen is also considered as the father of radiology. He has discovered X-ray on 8th of November, right? So 8th of November is also celebrated at World Radiology Day, right? This is going to be the 8th of November. Then we have got Godfrey Hounsfield, who has discovered what? CT scan. Hounsfield is a unit also for CT scan. This is the Hounsfield who has discovered what? CT scan. Lauterbach and Mansfield has discovered what? MRI. They have discovered what? MRI, right? Then we have got what? John White, he has discovered the medical ultrasound, and radioactivity was discovered by Henry Becquerel, right? And that is why the unit of radiology, radioactivity, we have got what? Becquerel, we have got the unit of radioactivity also, right? These are the important scientists, right? I'm going a little bit faster because this is the rapid revision, right? I've kept the things written, whatever is explainable I would be explaining you, right? So next thing we are having is going to be your x-rays. This is going to be x-ray. In x-ray, remember two things you have to understand. If something is appearing white is known as opaque area, white is known as opaque, and something is appearing more black is known as lucent. So remember just this important thing. Opaque means white, in white means opaque in the x-ray. In x-ray we call it what? Opaque. Okay. Lucent means black. Lucent means black. So in x-ray, lucent means what? Black. So we have got what? Radio opaque thing. Radio opacity is there. Opaque things will be there. Infiltrates are there. This is going to be what? This is going to be opaque, means something white is there, right? Lucent means radio lucent means it is going to appear what? Black on what? On x-ray. This is very important. You need to understand. They are talking always about what? They are talking about x-rays, right? They are talking about x-ray. Whenever they will write the term opaque and lucent, this means they are talking about x-ray. Second thing we have got is going to be your CT scan. In CT scan, remember, this cortex is going to appear white. This cortex is going to appear white, and in CT scan, white things are known as what? They are known as hyperdense. They are known as hyperdense and hypodense. Okay. So hyperdense means white thing, hypodense means black thing, right? Hypodense means less whiteness will be there. It is going to appear what? Black. Whereas in MRI, you will be finding what? In MRI, cortex you will be having, cortex is going to be black. Cortex is going to be black. Here you will be having what? Hyper intense and hypo intense things. They will be calling in the MRI. White is known as hyper intense. Hyper intensity will be there. That means something white is there. We will understand what is going to appear white on MRI, what is going to appear white on X-ray, right? So hyper intense means what? Hyper intense means it is going to be, intensity means it is going to be, they are talking about what? They are talking about the MRI. Right? CT scan will be talking about the density. It is going to talk about the intensity. So we have got hyper intense lesion. That means it is going to be white lesion. We have got hypo intense something. This means it is going to appear what? Black on MRI. Hypo and hyper intense. Very, very important. Next thing we have got is going to be your ultrasound. Ultrasound is going to be USG. Right? Ultrasonography. Right? Hyperechoic. Here we are going to name the thing echoic. Echoic means what? Echoic means white. Hyperechoic means more white. Okay. Hypoechoic means more black will be there, right? White lesion is known as, white thing is known as white. White thing is known as what? Echoic. White thing is known as hyperechoic, right? Black thing is known as hypoechoic. For example, like if you want to talk about this particular thing, like stones are going to appear what in the ultrasound. Remember, stones are going to be what? Hyperechoic. That means stones are going to appear what? White on ultrasound, right? Whereas hair is going to appear what? White on ultrasound. Bone is going to appear what? White on ultrasound, right? What is going to be black? Remember, this is going to be your serous fluid. If there is any fluid filled lesion, if there is any cavity, it is going to appear what? Black, right? If there is any kind of blood bleeding is happening, that is why we are doing what? E-fast. We are doing fast or E-fast. Anytime patient is coming with road traffic accident, maybe there is some bleeding happening at some part of the body, or you want to identify any fluid in the body, what you are going to do? You are going to do ultrasound. And what will you see in the ultrasound? You will be finding this black color thing. This black color is suggestive of what? This black color is suggestive of fluid. This black color is suggestive of fluid, right? So fluid is going to be black in color. Black color means you are talking about the fluid. White color means you are talking about the stones, so you are talking about the bones, you are talking about the air or fat cells, right? So this is going to be the basic funda we are having. X-ray, CT scan, MRI, USG. You need to see, you need to identify. You can appreciate. For example, this is your inferior vena cava. It will be having what? It will be having blood. Blood will be appearing what? White, right? We are going to see all those things. Okay. So we have got X-rays, we have got CT scan, MRI and USG, right? White area on X-ray is known as opaque area. White area on CT scan is hyperdense. On MRI, hyperintense, and USG is going to be hyperechoic lesion, right? The next thing we are having what is the X-ray and when we are going to use X-ray. This is something you should be knowing, right? So X-ray was initially used for what? Air anywhere in the body. If you are having air anywhere in the body, remember this air is going to appear what? It is going to appear black, and this black is known as what? Opaque or lucent. This is going to be radiolucent. Remember, air is going to be radiolucent. It is going to appear what? It is going to appear black, right? It is going to appear black. So anywhere air is there in the, like for example, in the cases of intestinal obstruction, what is going to happen? This is going to be your food pipe, right? Your food will be in the food pipe. It will be going to duodenum, jejunum, ileum. If you are having some obstruction or some kind of rupture will be there in the ileum, or perforation is there, what is going to happen? This air will leak from this duodenum, jejunum, and this air will come where? This air will come below the diaphragm in the peritoneal cavity. And right, you can simply see what? You can simply see on the X-ray, you will be finding air under the diaphragm. This is also known as cupula sign. I'll show you the image, right? This is going to be the air. If you have air somewhere in the leakages there, you can definitely identify. You are also having air in the lungs, right? Air in the lungs, you are going to do what? X-ray. This is going to be initial investigation, right? Anytime you have got any fractures, you are going to do what? For musculoskeletal fractures, you are going to do what? You are going to do X-ray. You are going to do X-ray. For arthritis also we are going to do what? X-ray. We are going to see the narrowing of the joint spaces, right? Narrowing of the joint spaces. We have got four classes we have got, right? This is the classification. We are going to see and identify which class this person is having, whether osteophytes are present or not. Like that we will understand about this arthritis component. What about this foreign bodies? If you are having any foreign bodies in the body, you are engulfing something, maybe a coin, maybe a battery, maybe something, right? For any time you are having a foreign body, maybe you are putting an endotracheal tube, or maybe you are putting a nasogastric tube, whatever is the foreign body, you are going to do first investigation. That is going to be what? X-ray. Okay. Then we have got certain devices, like we have got implantation, like a pacemaker. This is also we are going to do what? X-ray, and we can identify these things in the X-ray. So anytime in the hospital also, when you are sitting in the hospital, you need to identify air anywhere. Air anywhere. This is going to be first line investigation is going to be X-ray, right? If you find some fractures, you write X-ray. You already know about this arthritis X-ray. Foreign bodies in the body, first investigation, not MRI. Remember, MRI is contraindicated. Right? For foreign body, first investigation is going to be X-ray. Device identification, first investigation is definitely going to be what? X-ray. Right? Second thing we have got is going to be your CT scan. The CT scan is going to be investigation of choice. So initial investigation should be cost effective. It should be quick. It should be fastly available, readily available, right? So this is going to be the initial investigation. Investigation of choice is going to be something. CT scan will take 15-20 minutes, definitely, right? So this is going to be investigation of choice, right? Investigation of choice we are having. So we have got NC-CT, non-contrast CT scan for air anywhere in the body. It is also going to appear what? It is also going to appear which color? It is going to be lucent, right? Lucent, you will be studying lucent in the X-ray. Here you will be calling it what? Hypo dense or intense. This is going to become hypodense. Hypodensity will be there. That means what is there? That means black lesion is there. Black means this is going to be air. Then we have got what? Stones. Stones are going to be what? Stones are going to be hyperdense. Hyperdensity will be there in the stones. They are going to appear white in color, right? So what are the exceptions? Exceptions are going to be gallstones. Okay, you can do for you can do CT scan for all the stones, but the exception is going to be gallstone, where you are going to do what? Ultrasound, because these gallstones can be made up of other things also, like cholesterol, right? This which is not going to come out here. So for gallstone we are going to do what? Ultrasound. For all other stones you can do what? CT scan. For bones, the investigation of choice is definitely going to be CT scan. If you are not finding something in the X-ray, you can go for CT scan. But what is the exception? The exception is going to be stress fracture. If the stress fracture is there, this is going to be the MRI that you are going to do. Right? Stress fracture, you are going to do what? MRI. For all the foreign bodies, you can do what? You can do CT scan. For all the foreign bodies, you can do CT scan. Remember, this MRI is contraindicated. You are not going to do what? You are not going to do MRI. Right? For acute hemorrhages, any kind of bleeding that is happening, like for example, a patient is coming to us with some kind of trauma, road traffic accident, what we are going to do? First investigation that we are going to do is what? कोई patient after trauma, some patient is coming to you after a trauma, after road traffic accident. First thing, to identify acute bleed, this is the first thing we are going to do is going to be NCCT scan, right? We can do ultrasound also for internal bleeding, but for the head we are going to do what? Identification of acute hemorrhage, we are going to do what? We are going to do NCCT. Remember, this NCCT is not going to tell you about the diffuse axonal injury. For that particular purpose, we have to do what? MRI, right? You do NCCT, you find nothing in the NCCT, then you are having some deficiencies, you are having some focal neurological deficit is there, some symptoms are going to be definitely there, right? In that particular case, you will be going for the MRI. So for air anywhere in the body, the first line investigation is going to be X-ray, and the investigation of choice is going to be what? CT scan. We have got CT scan in different planes. We can go for axial plane, we can do it in the sagittal plane, we can do it in the coronal plane, right? We can cut it like that, we can cut it like that, we can cut it like that. Okay, and we are going to see all those thin slices of the body, right? I'll make you understand how to understand these things, right? Then we have got what? Then we have got MRI, then we have got what? MRI. MRI is going to be used for all the tumors, right? Where we are going to use MRI? For all the tumors, right? Brain tissues, PNS, spine, nerves, soft tissues, right? We are going to do what? MRI. So remember, MRI is something we are going to do to identify soft tissues. Like we need to see some nerves, some PNS, we need to see for spine, right? We need to look for nerves, all these things we are going to do what? MRI. What is this Pancoast tumor? This is a tumor of superior sulcus, right? For that particular purpose, you are going to do what? MRI. You need to identify the bone marrow edema, you are going to do what? MRI. You need to look for cartilage, soft tissue or ligament, you need to do what? MRI. For identification of cartilage, soft tissue and ligament, you need to do what? MRI. For any time in the body you are having chronic hemorrhage, you are going to do MRI. For acute hemorrhage, we are going to do what? CT scan. For acute hemorrhage, we are going to do what? CT scan. For chronic hemorrhage, we are going to do what? MRI. Right? We have got certain sequencing of the MRI. We have got T1 weighted image, T2 weighted image, and we have also got the FLAIR imaging. T1 weighted, remember this gray matter is going to appear gray. If T1, we are looking at T1, gray matter is going to appear gray. White matter is going to appear white. This is known as T1 weighted imaging. T2 weighted, remember T2, water is going to be white on T2, right? Water is going to be white on T2. So you can appreciate this water is appearing what? White on T2, right? But if there is surrounding tissue, inflammation is there, surrounding tissue edema is there, how we are going to identify? So we have developed another imaging that is going to be FLAIR mode. Remember FLAIR mode, just one thing you have to remember, gray matter will be appearing white here and white matter will be appearing what? Gray here. This is the identification. Gray matter will be appearing white. This is going to be what? FLAIR imaging. White matter is appearing white. This is going to be what? T1 weighted. Water is white. This means it is going to be what? T2 weighted imaging. T2 weighted imaging. Right? So MRI we are going to do generally for the soft tissues, for the brain, for the tumors, for the spine. Right? This thing we are going to do what? MRI. Then we have got ultrasound. Ultrasound is the investigation of choice in the cases of what? Fluid anywhere. Remember I told you fluid anywhere. This is going to be what? This is going to be anywhere you are going to have blood. What is going to happen? This fluid is going to appear anechoic or hypoechoic. We call it what? Hypoechoic. Black we call it hypoechoic. White we call it what? Hyperechoic. Right? So if you want to identify the gallstones, remember all stones we can do X-ray, we can do CT scan, right? For all other stones we are going to do what? We are going to do what? For gallstones we are going to do what? We are going to do ultrasound, right? If you want to identify ascites, ascites will be accumulation of fluid in the abdominal cavity due to decrease in the proteins, decrease in the albumin, right? This is known as ascites, and for ascites we are going to do what? We are going to do this particular testing. This is going to be what? Ultrasound. For pleural effusion, if there is a fluid in the pleural cavity outside the lung, there will be a cavity. Outside the lung, there will be a cavity. Suppose this is your lung, then we have got one more cavity outside this lung, and if you have accumulation of fluid in this cavity, this is known as pleural effusion. Pleural effusion. And if you want to identify this pleural effusion, you are going to do what? You are going to do ultrasound. You are going to do what? USG. If you want to see superficial structures, like you want to see for thyroid, you want to look for your superficial GIT things, you will be able to identify things on the superficial structure with the help of USG. Remember, USG cannot go deeper. Ultrasound waves cannot penetrate. They cannot penetrate deeper. Why? Because they are what kind of waves? They are ionizing or non-ionizing? They are going to be ionizing or non-ionizing. They are going to be, remember, they are going to be non-ionizing radiations. So they are not going to go deeper, and they are not going to identify this particular thing, right? So we have got some certain other scopes. We are having like other type of probes. We have got curvilinear probe. We have got linear probe. We have got endocavitary probe. We have got cardiac probe, which are going to be different. Cardiac probe, remember, heart is a moving structure. You are going to take the scan on the M mode, right? That is going to be the moving mode. This is going to be what? This is the cardiac probe you will be using. If you want to see inside the body cavity, if you want to go inside the esophagus, okay, if you want to see inside the esophagus, you are going to do what? You are going to use endocavitary probe. You are going to go inside the uterus. You are going to see the fallopian tube. You cannot do ultrasound of fallopian tube from outside, right? It is not going to penetrate, right, that much. So what is the principle of this particular ultrasound, beta? The principle for ultrasound is going to be your piezoelectric effect. What is this piezoelectric crystals we are having? Basically, we are having this crystals present over here. And the function of this piezoelectric crystals is what? It is going to convert the electrical energy into sound waves. It is going to convert the electrical energy into sound waves, and these sound waves will go to body. They will come back, they will reflect, and then they will come back. And the same piezoelectric crystal has another ability. It will convert the sound waves into electrical waves also, right? So it is going to convert sound waves into electrical waves, and then these electrical waves we can see in the form of images, right? So this is going to be the ultrasound that we are using. This is the ultrasound that we are using, right? This is going to be the basic funda. This piezoelectric crystal is made up of lead, lead, zirconium. This is made up of lead, zirconium will be there, right? Then you can appreciate over here, this is going to be a hyperechoic lesion. Hyperechoic matlab kya hoga? Hyperechoic means it is going to appear white. Hyperechoic means it is going to appear what? White, right? So how you can appreciate, this is going to be your gallbladder. This is your gallbladder, right? Why it is appearing black? Why it is appearing black? Because there might be some fluid, there might be some bile juices will be there. So that is why it is appearing what? Black. This is why it is appearing what? Black. And this black particular thing will be having what? Something white is over there, right? What is this white thing we are having? This is the stone. And because of the stone, what is happening? These rays are going, but they are not coming back, right? All the rays are coming back, but these rays are not able to come back, right? Here you are finding posterior. This particular thing is known as posterior acoustic shadowing. This is known as posterior acoustic shadow, which is very characteristic of what? Which is very characteristic of gallstones, right? So hyperechoic thing that you can appreciate over here, this is going to appear white. This is going to be your gallstones, bacha. This is going to be your gallstones. And when you have gallstones, what is going to happen? It is going to show you which type of acoustic shadowing. This is known as posterior. On the back side, you will be having acoustic, means sound waves are not going to go back, right? It is going to absorb the sound waves, and that is why this particular area, a hypoechoic area, you are going to find after this particular thing. This is known as posterior acoustic shadowing, right? Hypoechoic lesion, you will be finding, you can appreciate hypoechoic lesion will be having what? If you are having fluid anywhere, okay, if you are having fluid anywhere, can you appreciate, you are finding what? Posterior acoustic enhancement. This is going to be acoustic enhancement that you are going to see. This is going to be posterior acoustic enhancement. Why? Because it is not going to absorb the sound waves, and it is going to transmit all the sound waves as it is, right? So you will be having more sound waves here, and you will be having something white will be appearing after a black lesion. This is known as posterior enhancement. Okay, and if you are finding something very black, something very hypoechoic or anechoic, you can call it, this is known as cystic lesion. These are going to be cystic lesions. We can have this particular type of appearance in the bladder. We can have this type of appearance in the renal cyst also, right? So anytime you have cyst formation in the body, it will be appearing what? Whenever you are having fluid anywhere, it is going to appear what? Black. It is going to appear hypoechoic, bacha. It is going to appear what? Hypoechoic. Whenever you are going to have something like stones will be there, air will be there, it is going to appear what? It is going to appear white. It is going to appear white on ultrasound. Remember, for all other images, always remember this is going to be right side, this is going to be left side. For all other imagining, right? This is going to be the right side, this is going to be left side, right? Right and left. But for this particular one, ultrasound, remember there is no right and left. It depends on the person to person, right? So whatever person is using the probe is making what is the angle of the probe. This is going to decide the right and left of the person, right? So you can understand. We have got B mode, which is going to be the mode for brightness. We have also got the M mode, which is going to be the mode for motion, right? We are going to see in the M mode, we are going to see what? Heart. We are going to see what? Heart. And what is the probe we are going to use? We are going to use cardiac probe. And what we are going to do? We are going to do this thing. This is known as 2D echo. What we do in the 2D echo? You can simply appreciate heart is a structure which is going to have what? Blood. Which is going to have what? Blood, and blood is going to appear what? Blood is a fluid, and the investigation of choice for fluid is going to be what? 2D echo. We can identify the ejection fraction, we can identify multiple things over in the 2D echo, right? What is the problem we are having? We can easily identify them so that we can solve them also, right? So this is going to be the thing we are having. Let me just summarize everything for you. What we have discussed, we have discussed about the radiation. What is the radiation? Types of radiation. We are having X-rays, gamma rays, and non-ionizing radiations. Then we have discussed about certain scientists, important ones. Then we have discussed about what is going to be opaque, what is going to be dense, what is going to be intense, and what is going to be echoic, right? Hyperechoic means what? Hypoechoic means black, right? Then we have discussed about the X-rays, what are the X-rays and when we are going to use them, right? For air anywhere in the body, you are going to do what? X-ray. In the initial investigation of choice is going to be X-ray. Fracture, you are going to do what? X-ray. But remember, stress fracture is going to be something where you are going to do what? MRI, right? Anytime you have acute bleed in the body, you will be doing what? Acute hemorrhage in the body, you are going to do what? Non-contrast CT scan. We can use contrast also. I'll teach you what are the contrasts, right? We can also do in the MRI cases, we can also do MRI for the chronic hemorrhage. If someone is having chronic bleeding, we are going to do what? MRI, right? Soft tissue for bones, everything we are going to do MRI. For fluid anywhere in the body, we are going to do what? We are going to do ultrasound beta. Okay, for fluid anywhere in the body, we are going to do what? Ultrasound. Gallstones, we are going to do ultrasound. Okay, ascites, we are going to do ultrasound. Pleural effusion, fluid in the pleural cavity, fluid in the stomach, fluid in the not in the stomach, fluid in the abdominal cavity, we are going to call it what? We are going to do ultrasound. We are going to do what? Ultrasound, right? So we are done with this. Now we are going to discuss about the another thing. What is another thing we are having? It's about the radio sensitivity and radio resistant organs, right? So what are the radio sensitive organs? What are the radio resistant organ? Radio sensitive kaun sa hoga? First of all, what are the organs we are having radio sensitive? Remember beta, cells. First of all, let's talk about the cells. Any cell which is constantly dividing, any cell which is constantly dividing, like your germ cells, like your stem cells, they will be radio sensitive. They will be radio sensitive. They will be having effect of radiation. Whereas any cell which is not dividing, like for example neurons we are having, they are going to be radio resistant, right? So germ cells are going to be most radio sensitive cells. Okay, they will be asking this type of questions. What is the most radio sensitive tissue? Simple understanding, multiple cells are going to make what? Tissue, right? And these cells are going to be present where? Bone marrow is going to have very high mitotic activity. It will be having lots of division. What is the division we are having? We will be having division of RBCs, WBCs. Okay, so you will be having this bone marrow which is going to be more radio resistant and more radio sensitive, whereas fibrous tissues are going to be the most radio sensitive tissue. Most radio sensitive tissue, your answer will be what? Fibrous tissue, right? Most radio sensitive organ is going to be what? Radio sensitive organ is going to be what? This is going to be gonads. Same story, gonads will be having what? Division, right? Most radio sensitive blood cells is going to be your lymphocytes, and radio sensitive phase is going to be what? This is going to be your G2M. Okay, radio resistant, if they want to ask you, this is your previous year question, most radio resistant organ, this is going to be your vagina, right? In the blood cells we have got platelets, and in the phase we have got what? S phase. S phase is the most radio resistant phase, right? Then we have got some protective measures. What are the protective measures we are having? We are having this particular thing, this apron, that people who are working in the radio activity part department, they are going to have what, this apron. This apron is known as, what is the name of this apron? This is going to be lead apron. What is the thickness of this lead apron? This is going to be 0.5 millimeter. The thickness of lead apron is going to be 0.5 millimeter. The minimum thickness, if they ask you, your answer will be 0.25 millimeter. Minimum thickness will be 0.25 millimeter. This is going to be the lead apron, right? This is going to be the lead apron. Like in nowadays in the modular OT, we are having this coating of lead, right? We are having the coating of lead and some other material also, so that radiation will not pass from the OT, right? The radiation will not go to the another other rooms or chambers or outside the OT also, right? So we have got this lead apron. We are having lead apron. Thickness will be 0.5 mm. Minimum thickness they have asked, this is going to be 0.25 mm, right? Remember this TLD batch. What is this TLD batch? This is going to be thermoluminescent dosimeter. Thermoluminescent dosimeter. It is going to be identifying the dose of the radiation this particular patient is exposing. So always remember, this should be wear outside or inside the lead apron. This should be wear outside or inside the lead aprons. Remember बच्चे, this is going to be weared inside the lead apron, है ना? Lead apron के अंदर we have inside the lead apron we have to kept it, right? And this is going to monitor the dose of the radiation that this person is going to get exposed to, right? So what are the dose limits? You have to understand what is this TLD. TLD ki full form you need to understand what is TLD and what is the function where we are going to wear it. It is not going to be weared above the lead apron. It should be wear in inside the lead apron, below the lead apron. So this is how you are going to understand this patient is going to expose to how much of radiation, right? So we have got the doses limits for a patient. It is going to be what, 50 millisievert per year. 50 millisievert per year for a patient, right? For a normal person, it is going to be what, 1 millisievert per year. For a normal person, it is going to be 1 millisievert per year. For a pregnant female, it is going to be 5 millisievert per term. Per term means it is going to be the 9-month period. For a pregnant female, it is going to be 5 millisievert per month, right? For a worker, it is going to be what, 100 millisievert for 5 year or 20 millisievert per year. This is going to be the same thing, 20 millisievert per year for a worker, right? And 100 millisievert for per 5 year. This is going to be the dose limit. If you are exceeding this dose limit, you can check this dose limit through TLD batches that we are having, right? Why these doses are important? Because radiation can cause harmful effects, right? What are those harmful effects? We can have two types of harmful effect, beta. We can have deterministic effect, we can have stochastic effect. Deterministic effects are going to be effect because of high doses. They are the result of high doses. If someone is exposed to radiation for such a high period of time or such a long period of time, this particular effect are going to be known as deterministic effect. They have a threshold before they appear early or late, have a severity depending on the dose. Remember, the severity is going to depend on the dose. These effects are known as what? Deterministic effect. Dose dependent effect are going to be deterministic effect. And what are the examples? What are the things you can have? You can have cataract, you can have alopecia, right? Another one effect is going to be stochastic effect. Stochastic means what? Stochastic effect, because they may be arising from any dose. Like, because of why they are going to cause this type of effect? Because we do not have any known threshold. They have long latency period, have a probability of occurring depending on the radiation dose, right? So what is this stochastic effect? They are going to be happening because of some kind of mutations, right? You are exposed to radiation for some period of time, and then you have what, some mutations in your cell, and this mutations is going to lead to what? Cancer formation. It can even lead to other mutations also, right? So these are the two types of effect we are having. We have got deterministic effect, we have also got the stochastic effect, right? Deterministic means they are going to determined by the dose, right? Stochastic can happen at any dose. They arise from any dose, right? This can cause what? Cancer. This can cause what? Mutations in the patient, right? Basics you should be knowing, right? Then we have got certain units. What are the conventional unit? What are the SI unit we are going to follow? So for exposure, how much radiation is exposed to someone is calculated by the conventional unit. What is the conventional unit for radiation? This is going to be what? Roentgen. Roentgen is the conventional unit for radiation. Whereas what is the SI unit for radiation? This is going to be your Coulomb per kg. The SI unit for radiation is going to be Coulomb per kg, right? For the dose identification, we are going to do what? Rad. We are going to do the rad, or SI unit is going to be what? Gray. SI unit is going to be the gray. For dose equivalent, we are going to do what? Ram. And here we are going to understand with this particular thing that is going to be the SI unit is going to be Sievert. For radioactivity, we are going to use what earlier we used to conventionally we are going to use the Curie, but now we are using SI unit, that is going to be the Becquerel, right? Becquerel, right? So we have got R, we have got this particular thing. Okay, this rad and Ram and Curie, these are the conventional unit. We have got Coulomb per kg, we have got Gray, we have got Sievert, we have got Becquerel. These are going to be the SI unit. These are going to be the SI unit. Then comes the next thing and the basics of radiology. The next thing is about the contrast. Next thing is about the contrast. What are the contrast we are going to use? What are the color we are going to use? The first contrast. Contrast means what? We are going to use the color, right? Contrast means color, right? So we can use barium sulfate. We give the patient barium sulfate to drink. This patient will be drinking the barium sulfate, right? Remember, this is contraindication in the cases of perforation or some kind of esophageal fistulas. If you are having some perforation, what will happen? This barium that you are drinking will be going out into the body, and this is how you are going to make this thing come out, right? This is going to be the perforations we are having. So perforation patient, we are going to not give what? Barium study, right? For tracheoesophageal fistula, it will be doing what? You are putting something in the esophagus, it will go to trachea, it can cause what? It can cause aspiration, right? You can have problem, right? So we are having these barium studies. We can do barium, we are giving the barium and we are taking a x-ray. We can do barium swallow, we can do barium meal, we can do barium follow through, meal follow through, we can also do barium enema. So I'll make you understand how this barium is going to work. But one thing you need to understand, this barium is going to appear what color? This barium is going to appear, this is going to be a radio opaque thing or radiolucent. Remember, this is going to be a radio opaque thing. That means it is going to appear white in color. It is going to appear white in color. This is going to be a radio opaque thing, right? So we have got this particular first thing. The energy we are going to use is going to be what? The source of light we are going to use, the energy we are going to use is going to be x-ray. We can do x-ray, right? For x-ray and CT, we are going to use all the iodinated contrast, like we are having iohexol, okay, iodexanol, iohexol. These are going to be your iodinated contrast. Remember, they are going to be radio opaque. Matlab, which color will be there? Radio opaque means they are going to be showing you which color? White color. So when you want to see something, you give what? You give injection, you give injections, you give this particular contrast. What is the contrast we are having? This contrast is going to be iodinated contrast always. Remember, this is going to be iohexol or iodexanol. These are going to appear white in color. So if you want to see any vessel, you want to do CT angiography, you want to see any organs, you want to see any GI tract or CT scans, right? What you are going to do, you are going to use this iohexol or iodexanol. These are going to be non-reactive things. They will be coming out through the kidney, right? So this is known as contrast enhanced CT scan, when you are putting something which is going to appear what? Radio opaque on the x-rays, which is going to appear hyper dense on the CT, hyper dense on the CT. This material that you are putting is going to make the CT hyper dense, right? This is going to be the x-ray and CT. Second dye we are having is going to be, in the cases of MRI, we are going to use what? Gadolinium based agent. We are going to use gadolinium based agents. These are going to be the dyes we are going to use, and these dyes are going to be gadolinium based dye, right? These are going to be signal enhancer. Basically, they are going to cause what? Hyper intensity. They are going to cause hyper intensity beta. They are going to cause hyper intensity, right? So they are going to make the things what? Appear more whiter, right? More whiter, right? So we can use this particular thing for brain, spine, or some kind of vessels. We can do what? MRI. And what is the dye we are going to use? This is going to be gadolinium. For ultrasound, bache, we are going to do what? We are going to use micro bubbles contrast. For ultrasound, we are going to use what? Micro bubbles contrast, right? We are going to use micro, small bubbles of air. Remember, air is going to be hyperechoic or hypoechoic. This air is going to be hyperechoic. This is going to be hyperechoic, which is going to make the things white, right? It is going to make the things bright, right? So we are having this micro bubble contrast, and we can use this for cardiac, vascular, or ultrasound, right? Liver ultrasound. This is going to be known as sonoview. We have got this particular thing as sonoview, which is having sulfur hexafluoride, which is having sulfur hexafluoride. When we are going to give this sulfur hexafluoride, you will be having this lots of small bubbles, micro bubbles will be there. We can see the things very easily, right? And no need to worry, this is going to come out through the lungs, so no need to worry about that also, right? Ultrasound. Lastly, we have got what PET-CT. What is this PET-CT? Here you are going to give radioactive material. What is the radioactive material we are going to give? That is going to be the glucose, right? We have already known about this fact that whatever you are going to eat is going to go to what? It is going to go to your blood vessel, right? Same way, you will be using what? You will be injecting the radioactive FDG glucose, right? Fluorodeoxyglucose. You are going to give the glucose FDG. We are having 18 like that, right? So this is a radioactive isotope. When you are going to give this glucose will be traveling all around the body through blood, right? Blood is the connective tissue. It is going to make the connection throughout the body, and this glucose will be traveling throughout the bodies. Now what will happen? Cancer cell are going to be high mitotically active cells. They require what? Division. There will be, what is cancer? Uncontrolled division will be there. So whenever you are having this uncontrolled division, what is going to happen? This glucose is required for the division process, right? So this FDG uptake will be more where? Those parts which are having uncontrolled division, those parts which are having what? Cancer cells. This is how we will understand those parts which are having what? Cancer cells will be having what? Glucose. They are eating what? Glucose. And if they are eating glucose, what is going to happen? You will be having more number of divisions will be there. So this is how we are going to understand. We are going to give fluorodeoxyglucose to the patient. We will wait for some times, and then we are going to take the scan of this particular patient. This is going to be known as PET-CT. This is going to be known as PET-CT, where we are going to take the radiation. We are going to understand if you are finding some hot uptake is there, some parts of the body who are having more uptake, right? More uptake apart from normal. If some part, for example, my like let's say some part of the vertebra is having more uptake, you can simply understand that this vertebra is having what? Cancer cells. So this is used for identification of what? Metastasis. This is used for identification of metastasis identification. We can do what? We can do PET-CT. We can do what? PET-CT, right? So these are the basics that you should be remembering, when to do, what to do. So we are done with the basics of radiology. Now I would like to focus on the important parts. What are the utilization of these things that we have understood, right? For example, air anywhere in the body, you are going to do what? Try to answer. You are going to do first initial investigation that you are going to do, and what is going to be investigation of choice? Yes, initial investigation we are going to do air anywhere in the body is going to be X-ray, and investigation of choice is going to be CT. What happens if there is a fluid anywhere in the body? What would you like to do? Any kind of fluid in the body, you are going to do what? Ultrasound. You are going to do what? Ultrasound. This ultrasound, what is the appearance of the fluid? It is going to be, yes, it is going to be anechoic, it is going to be hypoechoic, or simply you can call it is going to appear black. It is going to appear black. Along with that, you will be having what? Posterior acoustic enhancement will be there, right? Along with that, you will be having posterior acoustic enhancements. Posterior acoustic shadowing is seen with the stones. Stones are going to appear what? White. White means hyperechoic, hypoechoic. This is going to be hyperechoic lesion, right? In the reports, you will be finding these things only: hyperechoic, hypoechoic, hyperintense. Hyperintense means what they are talking about? They are talking about MRI. Hyperdense means what they are talking about? They are talking about something white on the CT scan. Hyper opaque, or you can say radio opaque. Radio opaque means something white is appearing on the X-ray, right? So you can understand these things with the help of this basic understanding. Now we will be discussing about the gastrointestinal system, about the GIT, right? We will start it off with the systems, right? So we will be starting it off with the first system in the list. What is that first system in the list we are having? This is going to be your gastrointestinal tract, right? So we can use what? First thing, we can give barium to the patient. These are the barium studies that we are having. right? We can give barium to the patient, and this is known as first one, that is known as barium swallow, right? When you are giving barium to the patient, patient will be drinking the barium, and as soon as you are going to take what X-ray, this is going to be barium swallow that we are having. What appearance you will be having? You will be getting this bird beak appearance in the cases of achalasia cardia. Okay, in achalasia cardia, lower esophageal sphincter is failure to relax, right? This lower esophageal sphincter is failing to relax. What is going to happen? You will be having this bird beak like appearance. This is going to be characteristic feature of what beta? This is going to be seen in the cases of achalasia cardia. We can also have dysphagia, and remember, this dysphagia is for the liquid more than solid. Solid dysphagia you will be finding in esophageal cancers, right? Next thing we have got, what is the treatment? We can do Heller's myotomy, remember, with fundoplication beta, fundoplication, Heller's myotomy, right? You are going to cut this particular area, you are going to connect this area directly to the stomach. This is going to be achalasia cardia, right? Another barium study is going to be barium meal. This is going to be barium swallow. You are giving barium, this barium will be in the esophagus, you are taking the X-ray. This is barium swallow. If this barium is in the stomach and you are taking X-ray after like 10, 15, 20 minutes, you will be having what? Barium meal. Okay, it is going to tell us the story about the stomach and this particular part of the proximal duodenum, right? Proximal duodenum, you can take the X-ray based on the timings, है ना, कितने देर में and how much time you will be getting the food, will be getting where. This is going to be your barium meal. If this barium is going to go to your small intestine, this is going to be what? This is known as barium meal follow through beta. Here you can appreciate the jejunum, you can appreciate the ileum. This is going to be the small bowel that you are having. This is known as barium meal follow through. And lastly, we have got barium enema, where you are going to inject what? You are going to inject the barium from the lower side, and this barium is going to be there, and this is known as barium enema. It is going to tell us about the story of large bowel beta. Large bowel can be understood with the help of this particular one, right? You can appreciate this is the large bowel that we are having, right? Then we have got Zenker's diverticulum. If there is any dilatation over here, this is the dilatation over here. This is known as Zenker's diverticulum that we are having. Here you will be having what? Dysphagia. Here you will be having regurgitation. The food will be coming out. Halitosis, bad breath will be there due to accumulation of the food, right? You are going to cut this particular part, or you are going to fix this particular part over here. This is going to be your Zenker's diverticulum beta, na? This is a diverticulum that is going to happen because of weakness here, है ना? यहाँ पर out pouching हो जाएगा. You will be having out pouching over here. This is your Zenker's diverticulum beta. Then we have got what? Then we have got hollow viscous perforation. How you are going to understand the viscous perforation beta? Always remember, you will be looking for the sign. The sign is known as air under the diaphragm beta. Air under the diaphragm. So anytime you have what? You have the alimentary canal. Anytime you have anywhere rupture, what is going to happen? The gas will come out from the ruptured part, and this gas will be coming. This gas will be going up, right? It will be going up, and it will be accumulating below this part of the diaphragm. This is going to be the right side. This is going to be the right side. This is going to be the left side. Always remember, right is going to be on the this particular side, and this is going to be left side, right? So you will be having stomach here. If there is a gas here, that is completely fine, no issues. But if you find air here, okay, if you find air here, this is going to be what? This is known as cupula sign. This is known as mistake sign. This cupula sign or mistake sign, very characteristic of what? Hollow viscous perforation. Okay, investigation of choice for air anywhere, you can remember, first thing you are going to do is X-ray, and investigation of choice is going to be your CT scan beta, CT scan. Then we have got two types of diaphragmatic hernia. One is going to be your Bogdelic hernia, another one is going to be your Morgagni hernia. So this is your Bogdelic hernia, where you will be having most common site. This is the most common type of congenital diaphragmatic hernia, right? The content of diaphragm will be going into the towards the lung. This is going to be the most common congenital diaphragmatic hernia. This is going to be your Bogdelic hernia. This is going to have what kind of defect beta? Always remember, this is going to have posterior lateral defect, okay, and generally it is more often on the left side. Remember, this is going to be the right side beta, this is going to be the left side beta, है ना? So this is going to be what? This is going to be left sided hernia. This is known as Bogdelic hernia. Another one we have got is going to be your counterpart. This is going to be your Morgagni hernia. Morgagni hernia is less common congenital diaphragmatic hernia, only 2%. This one was 90%. right? Here the defect is going to be anterior, and this is going to be generally seen on the right side beta. This is going to be on the right side beta, right side will be there. Okay, then we have got some air bowel sign. This is going to be your single bowel sign. Okay, single bowel sign with non-bilious vomiting, olive shaped mass if it is given. This is going to be CHPS or biliary. You will be having this atresia will be there, right? If you find double bowel sign, this is going to be the case of duodenal atresia. You will be having duodenal atresia will be there, double bowel, right? Triple bowel sign is suggestive of what? It is suggestive of jejunal atresia beta, jejunal atresia, right? And multiple air filled, multiple bubble sign is going to be suggestive of what? Ileal atresia. Ileal atresia, you can appreciate multiple bubbles. This is going to be ileal atresia. So single bubble, this is going to be CHPS or biliary atresia you will be having, right? This is going to be double bowel. This is going to be duodenal atresia. Triple bowel is going to be what? This is going to be jejunal atresia. And multiple bowel is going to be what? This is going to be ileal atresia beta, ileal atresia, right? Then we have got the obstructions, and we will try to understand how we are going to assess this obstruction. So we can have small bowel obstruction, we can have large bowel obstruction. In small bowel obstruction, you can identify this horizontal plica circularis beta. These are your horizontal lines, and remember the diameter is going to be what? 3 centimeter is going to be the maximum diameter, right? But whereas in the large bowel, the diameter is going to be bigger one. Diameter is going to be 6 centimeter is going to be what? Bigger diameter, right? So large bowel is going to have what? Bigger diameter. Small bowel is going to have what? Smaller diameter, right? Here you will be having lines all the way across the bowel, right? You will be finding these lines. These are known as plica circularis, right? And here you will be having lines will not be there. Fully across will be hostras will be there. You will be finding the hostrations will be there. Hostrations will be there, right? This is going to happen in the central part, whereas this is going to happen in the periphery part, peripheral, right? So these are the bowel obstructions that we are having. This is going to be your small and large bowel obstruction. Investigation of choice is going to be your CECT, contrast enhanced CT scan we can do. Then we have got diverticulosis and diverticulitis beta. Diverticulosis and diverticulitis, right? These are going to be your small outpouching that you are finding. So you can appreciate these are known as these small outpouching that we are having in the intestine. This is known as what? Diverticula. These are the small outpouching that we are having. They are known as what? Diverticula. And if there is inflammation of these diverticula beta, or if there is infection of these diverticula, what do we call it? We call it what? Diverticulitis. Diverticulitis. We call it diverticulitis. And what kind of appearance you will be having in the diverticulosis? You will be having this sawtooth appearance on barium enema beta. This sawtooth like appearance on barium enema is going to be suggestive of what? This is going to be suggestive of what? Diverticulosis, right? We can do barium enema because this is going to be somewhat in the in this particular large intestine part, right? So you will be having sawtooth pattern on barium enema. This is going to be what? This is going to be diverticulosis. Okay, investigation of choice is going to be CECT abdomen beta. You can do what? CECT of abdomen, right? Here you will be having this coffee bean appearance on X-ray beta. कैसी appearance होगी? What kind of appearance? You will be having coffee bean appearance. This is suggestive of what? Sigmoid volvulus beta. This is suggestive of sigmoid volvulus, where you will be having twisting of the sigmoid colon going to give you what? Coffee bean appearance. Twisting of sigmoid colon is going to give you coffee bean appearance beta. Twisting of sigmoid colon is going to give you coffee bean appearance on X-ray, right? Then we have got Crohn's disease and ulcerative colitis. You can remember Crohn's can happen anywhere. Okay, Crohn's can happen anywhere. It can happen anywhere from mouth to anus. This is going to be your Crohn's disease. Whereas ulcerative colitis is going to start from colon. It is going to start from rectum. It can come till the colon. You know? So you can have this particular thing in the colorectal involvement will be there. In Crohn's disease can happen anywhere. You will be finding which lesions in Crohn's disease. These lesions are known as skip lesions. You can have involvement here, you can have involvement here, you can have involvement here. You will be having these lesions. These lesions are known as skip lesions beta, skip lesions. Okay, here you will be having inflammation. Entire thickness of intestinal lining will be having the inflammation. Whereas here in ulcerative colitis, innermost interstitial lining will be innermost intestinal lining will be involved here. right? Here you can have complications like fissures will be there, fistula formation, another complications are going to be there, stricture formation, you will be having fissure formation, fistula formation, abnormal connections can be there. Whereas in ulcerative colitis, you can have what? Toxic megacolon, you can have hemorrhages, right? It can have less risk of cancer, it can have high risk of cancer. This is the only disease where smoking is going to be what? Beneficial. Smoking is beneficial only in one disease. This is going to be what? This is going to be ulcerative colitis. Okay, here you will be having this particular appearance. This is known as lead pipe appearance. Lead pipe appearance, beta. Lead pipe, what is going to happen? There will be loss of ostrations, beta. Loss of ostrations, this is known as what? There will be loss of ostrations, this is known as what? This particular appearance that you are having, this is known as lead pipe appearance, a very characteristic of what? Ulcerative colitis. The drug of choice for ulcerative colitis is going to be sulfasalazine, beta. Sulfasalazine, which is a 5-ASA derivative. Whereas in this Crohn's disease, you can give steroids and you can find the specific findings. These are the stricture formation. Okay, you can have string formation, and this characteristic feature you will be finding is going to be your string sign of Cantor, beta. String sign of Cantor. String sign of Cantor will be positive over here. This is going to be string sign of Cantor. This is going to be Crohn's disease. This is your ulcerative colitis. Hepatobiliary system, what you are going to learn, the most important thing is about the hydatid cyst, and this hydatid cyst is because of a dog tapeworm. This is going to be your dog tapeworm, also known as Echinococcus granulosus. When it is going to invade your liver, it is going to cause what? This hydatid cyst, right? The classification that we are following for this hydatid cyst is known as what? Gerby classification. We have got WHO classification, we have got Gerby classification. Gerby was the older one, but they have asked question in the last examination. So we can use Gerby classification. We are currently using what? WHO classification for the hepatobiliary, this particular hydatid cyst, right? What is the treatment? We are going to do what? We are going to do pair, beta, pair. P4, we are going to do what? Puncture. We are going to do aspiration. We are going to do what? Injection, and then we are going to re-aspirate the thing. Right? What is the injection you are going to use? You are going to use ethanol hypertonic saline. What you are going to use, beta? You are going to use ethanol hypertonic saline over here. What kind of appearance you will be having? This classification will be having C1, C2, C3A, C3B, C4 and C5. This is the classification, right, that we are having. Remember, these two are going to be active, these two are going to be transitional, and these two are going to be inactive form. These two are going to be inactive form. You can have this honeycombing in this C to multiple septations will be there. This is known as honeycombing sign, right? This is going to be your detached membrane is known as the which sign? This is going to be your water lily sign that you can appreciate. Very, very important, right? This cotton wool sign you will be finding in the CE4 stage. Cotton wool appearance in the C4 stage, right? This is going to be CT imaging. This is going to be what? WHO ultrasound imaging, beta. Ultrasound imaging. So we can have this classification based on ultrasound and CT. This classification is going to be a WHO classification. We can also follow what? Gerby classification. The treatment remains simple. This is going to be pair. Along with that, you can also give drugs like albendazole, right? This is going to be the basic hepatobiliary thing we are having. Then you can do what? Then you can do MRCP and ERCP, beta. What is MRCP? MRCP is magnetic resonance cholangiopancreatography, beta. Magnetic resonance cholangiopancreatography. Cholangio means bile duct. Pancreato means you are going to see pancreas also. So this is going to be a T2 weighted type of imaging, and remember, T2 water is going to be white on T2, so you can easily appreciate all the things, all the juices that we are having, you can easily appreciate. And this is going to be a magnetic thing. That means it is going to involve what? MRI only, and MRI is non ionizing type of radiation, so it is not going to cause any major harms, right? This is going to be a diagnostic tool for bile and pancreas pathology. This is going to cause what? This is going to be the investigation of choice. But if you suspect something and you already know that you can have on the basis of symptom, so we go for ERCP. What is this ERCP? This is going to be endoscopic retrograde cholangiopancreatography. This is going to be gold standard, beta. Gold standard is going to be what? It is going to do the treatment also. It is not just the investigation modality. It is also going to do what? It is going to be responsible for the treatment purpose also. So what is this thing? You will be having an endoscope. You can see all the structure. This is going to be what? Endoscopy plus X-ray we are going to do. Continuous X-rays we are going to do. Continuous X-ray or live X-ray is known as what, beta? This is known as fluoroscopy. This is known as fluoroscopy we are going to do, right? Here we are going to put the contrast, and we can take the live X-ray, and we can also do what? We can use this ERCP machine, which is going to have what? Endoscope. And this endoscope is also going to do not just diagnosis but the therapeutic procedures also. So it is responsible not just for the diagnostic but also for the therapeutic procedures also. So it is for the diagnostic as well as therapeutic procedures, right? Then we have got what? Then we have got this particular one in your gallbladder. You can have what? This type of shadowing. If you are finding, this is going to be your gallbladder, beta. And what kind of lesion you are having, you can appreciate. This is going to be your hypoechoic thing we are having. Hypoechoic is what? Normal. This hypoechoic means what? There will be some kind of fluid. It is okay to have fluid in the gallbladder. It will be having what? Bile. But can you appreciate this white color structure? What is this white color structure? Is going to be what? It is going to be hyperechoic structure. This is your hyperechoic structure that we are having, and you can appreciate this hyperechoic structure is taking up all the radiation, all the sound waves, and it is not transmitting anything back, right? And you are having what? You are having this particular thing, black color shadowing over there, right? So this black color shadowing that you can appreciate over here, this is known as what? Posterior acoustic shadowing, beta. This is known as posterior acoustic shadowing, which is characteristic feature of cholelithiasis, which is characteristic feature of cholelithiasis. The investigation of choice is going to be what? You will be doing what? Ultrasound. You will be doing what? Ultrasound. USG is going to be the investigation of choice for the stones in the gallbladder, beta. Stones in the gallbladder. Other stones you can do X-ray, you can do CT, right? Then we have got comet tail appearance, comet tail sign. This is the comet tail sign that you can appreciate. This is for the adenomyomatosis, beta. This is for the adenomyomatosis. Adeno means glands, myo means muscle, matosis is going to be the hyperplasia. You will be having the hyperplasia of the gallbladder cells, right? You will be having hyperplasia over here in the adenomyomatosis, and you will be having what kind of sign? This type of sign is known as what? This type of sign is known as what? This type of sign is known as comet tail sign, and this comet tail sign is suggestive of what? This is suggestive of adenomyomatosis, beta. Adenomyomatosis, right? This is going to be the thing we are having. You can also have stones. You can also have posterior acoustic shadowing also, right? So this is going to be the adenomyomatosis. Then we have got some X-rays on the genitourinary system. We have got what? Genitourinary system will be having what, beta? You will be having kidney, you will be having urethra, you will be having bladder. And we can do the X-ray of kidney, urethra and bladder. You will be finding what? You will be finding the stones. Can you appreciate the stones in this particular case? You will be having here kidneys will be there, right? This is going to be the calyx that we are having. From that particular thing, you will be having this ureters coming, and both the ureters are draining into the bladder, right? So you can see the kidney, you can see the ureter, you can see the bladder. This is known as KUB X-ray. This is known as kidney, ureter and bladder X-ray. This is going to be the normal thing. Now you can appreciate here we are having some stone. This is going to be structure that you can appreciate over here. This is going to be the radio opaque structure that we are having over here. And because of this radio opaque structure, what is going to happen? You are not having the fluid coming below. And if the fluid is not coming below, can you appreciate that like ureter is gone? This ureter is not visible. This ureter is not visible. This is going to be the kidney stone that we are having. And because of that kidney stone, what is going to happen here? You will be having more accumulation. This is going to be hydronephrosis. This is going to be hydronephrosis. You will be having more water accumulation in the kidney because of the stone formation, right? And this patient will be having the pain. You understand this? You got this, right? So this is going to be urolithiasis, right? Another thing we can do IVP. This is going to be intravenous pyelogram, beta. Intravenous pyelogram. This is known as intravenous pyelogram. So we are going to give a drug intravenously, and we are going to take a X-ray. This is known as pyelogram. This is known as pyelogram. So when you can appreciate this drooping lily sign, can you appreciate the same sign over here? This is also considered as what? Drooping lily sign. This is also considered as drooping lily sign, and this is seen in the cases of duplication of the ureter, right? So you will be finding this particular thing in the cases of ureteric duplication with the upper moiety, right? So this is going to be what, due to ureteric duplication, this sign you will be finding. This is normal, this is okay, this is completely fine, this is normal, right? But here you are finding what, this sign is known as drooping lily sign. This sign is known as drooping lily sign, seen in the ureteric duplication beta. Okay, another one we have got is going to be your flower vase sign. We have discussed all those things in details. This is a quick recap, we are going faster, right? So we have got what, duplication. After that we have got what, flower vase sign or joining hand sign. Can you appreciate these two kidneys? These two things are the kidneys, they are joining together, they are joining together. This is known as what, this is known as, they are joining together, their hands are joining, this is known as joining hand sign. This is known as flower vase sign that we are having. This is going to be the flower vase sign. This is going to be the flower vase sign that we are having, which is seen in the cases of horseshoe kidney beta. Horseshoe kidney, you will be having what, this particular sign, you will be having this particular sign in the cases of horseshoe kidney. All right, the next thing we have got is staghorn calculi. Can you appreciate this type of lesion that you are having, this type of opacities that we are finding? This is going to be what, this is known as staghorn calculi. Okay, this is known as staghorn calculi. This staghorn calculi can be due to what, it can be due to proteus infection beta. Proteus infection can lead to what, staghorn calculi, or you will be having what, you will be having screw-white stone formation due to change in the pH, right? You will be having what, this stone is made up of magnesium, ammonia and phosphate. These are going to be the things we are having. Okay, what you can do, you can do PCNL, you can do percutaneous nephrolithotripsy, right? You can break the stones from outside. You are going to give something, and because of that, what is going to happen, you can break the stone, right? Then we have got what beta, we have got retrograde uretropylogram. Retrograde uretropylogram beta. Here you can appreciate the urethra is not visible. This is going to be retrograde uretropylogram, right? So we are going to inject our thing into the ureter. We are going to inject our dye into the ureter. We are going to come via bladder, we are going to inject our dye into the ureter. This is going to be retrograde. Since we are coming from the backward direction from the urethra, we are going to come to the bladder, and then we are going to inject our dye into the ureter. This is known as retrograde uretropylogram. Are you PG? Dye is going to given to the ureter via bladder, right? Remember beta, here urethra is not going to get visible, है ना? यहाँ पर urethra is not going to get visible. Then we have got MCU. What is MCU? Is going to be your micturating cystourethrogram. Micturating means this patient will be micturating. Cysto means you will be having involvement of bladder, and urethro means this is going to show you what, this is going to show you the urethra also, right? So here we are going to put a catheter, and this dye is going to go to the bladder, right? This dye is going to go to the bladder, and once the dye is in the bladder, we are going to tell our patient to do what, we are going to tell our patient to do what, urination. Once this patient is trying to do the urination, we can find multiple things, right? Ureters and kidneys are not going to be visible here. We can check for the vesico-ureteric reflex also. Vesico-ureteric reflex means because of the vesicle, this particular thing is going go back into the ureter. We can check for any injury over here, right? We can check for prostatic urethra, we can check for veromomentum, we can check for membranous urethra, bulbar urethra, right? Penile urethra. So we can check for multiple things over here, right? Lastly, we have got retrograde urethrogram. This is specifically used for what, for the urethral injury, any kind of urethral injury. We are going to inject our dye here, right? We are going to inject our dye here, and we are going to check for what, any leakage is going to be there, right? So it is the investigation of choice for urethric trauma. Okay, porthole injury, there are many causes for this urethric trauma. In this urethric trauma, what can happen, you can have opening somewhere, you can have trauma somewhere, and because of that, what can happen, this from this urethra the urine might be coming out, right? And if this urine might be coming out, you can check for this particular thing. This is known as retrograde urethrogram beta. This is known as retrograde urethrogram. All right, then we have got what, then we have got this particular x-ray. This is the This is the X-ray we are doing. You can appreciate this call, this stag horn. You can appreciate this is looking like a stag horn calculi, right? So in IVP it is going to be positive. It is going to be positive in IVP. It is going to be positive in normal X-ray also, right? You can see this particular thing. It is going to be radio opaque, right? So you can have this radio opaque stag horn calculi. This is the stag horn you can appreciate, right? Then we have got the stones. You can do what CT scan for the stones, and you can find the stones in the kidney also, right? You can find this is the kidney that we are having, and in this particular kidney you are finding what some stones, right? Which is going to be hyper dense structure. Hyper dense structure. This is going to be what? Hyper dense structure. Hyper dense means white appearance. This is going to be your stones, right? Investigation of choice for stones is going to be what? CT scan. Investigation of choice for stones is going to be what? CT scan, right? Then we have got some other stones that we are having in the bladder. We can have this jack stone. This jack stone calculi will be having what, beta? It will be having this pointed edges. Can you appreciate these pointed edges are going to be there? This is going to be this is going to be jack stone calculi, right? We can have this fibroid. Remember, this fibroid is not going to be in the midline, right? This fibroid will be in one side. You will be having this fibroid over here. This is a calcified fibroid, right? And then we have got what? Then we have got the putty kidney. Putty kidney is also known as the shrunken kidney, beta. Putty kidney is also known as the shrunken kidney. We have got this shrunken kidney. This is known as putty kidney. Putty kidney, right? Here you will be having cortical nephrocalcinosis. Here you will be having what? Cortical nephrocalcinosis. Okay, cortex part mein you will be having nephrocalcinosis, right? This is going to be because of genitourinary TB. Why this thing is going to happen? Putty kidney is because of genitourinary TB, beta. Genitourinary TB. Okay, the next thing we have got is the uretrosil, where you will be having a specific appearance. Can you appreciate this is a specific appearance that you are having? This appearance is known as cobra head appearance. This appearance is known as uh, adder head appearance, cobra head appearance of the ureter. This is seen in the cases of what, beta? Uretrosil. This is seen in the cases of uretrosil. You will be having this type of appearance. Normal ureter would be appearing what? You can appreciate normal ureter would be appearing like that. Normal ureters will be going like that. It will not have the any bulging like that. Okay, so if you are finding this type of bulging, this is going to be suggestive of what? This is going to be suggestive of adder head appearance. This is suggestive of uretrosil, beta. Uretrosil will be there, right? Then we have got this Christmas tree like or Christmas tree appearance of the bladder that you are finding. This is seen in the cases of neurogenic bladder. This is seen in the cases of neurogenic bladder, beta. Okay, then we can have this multiple cyst. You can appreciate this type this type of lesions that you are finding. These are your multiple cyst that you can appreciate. This is going to be your polycystic kidney disease, beta. This is going to be your multiple cyst will be there, multiple bilateral cyst will be there, and this is going to be PKD. This is going to be autosomal dominant polycystic kidney disease, right? Here you will be having hypertrophy of the kidney hypertrophy will be positive, right? And this particular sign that you are finding very very important, a patient will be coming to you with the symptoms of diaphoresis, sudden episodes of palpitations, anxiety, continuous this thing is happening. This is a possibility this patient might be having a tumor of adrenal gland, and this tumor of adrenal gland is known as adrenal medullary tumor. This is known as pheochromocytoma, beta. This is known as pheochromocytoma. And remember, on MRI you will be finding this light bulb appearance. On MRI you will be finding these are the kidneys. Above kidney you will be finding this light bulb appearance. This is going to be suggestive of what? Pheochromocytoma, beta. This is suggestive of pheochromocytoma. Okay, you can have plasma metanephrine. You can check for 24 hours urine metanephrines also. Okay, in the treatment part you will be doing what? You will be doing multiple things. In the treatment part you will be giving this patient preoperative and some antihypertensive drugs intraoperatively like phentolamines or phenoxybenzamine, right? These are the things you would like to use during the removal of this particular tumor. This is a tumor which is going to activate your adrenal medulla, leading to increase in the epinephrine, norepinephrine, dopamine, right? When you have an increase in epinephrine, norepinephrine, dopamine, you will be having overactivity of sympathetic nervous system, and overactivity of sympathetic nervous system will be very, very detrimental for us, right? This is going to cause palpitation, this is going to increase a high BP, you will be having multiple sympathetic system will be there, right? All the symptoms are going to come from the sympathetic nervous system, right? So we are done with this. Now the next thing, next chapter we are going to discuss in the next part, that is going to be CVS beta, CVS. So what are the things we need to look for in cardiovascular system? We need to understand what are the things we can appreciate over here. This is going to be the border of right atrium beta. This is going to be the border of right atrium. This is going to be the border for left ventricle. Here you will be having this aortic knob. Here you will be having somewhat left pulmonary hilum will be there. Pulmonary artery will be going from here, right? Here you will be having right pulmonary artery over here. These are the vascular marking, bronchovascular markings that we are having. Here you will be having carina, and below this carina will be what? You will be having division for the hilum. Whenever we are going to put a ET tube, we are going to keep our ET tube 2 to 3 centimeter above carina, right? This is going to be carina. These things you already know. This is going to be trachea. Since we are going to learn about the deviation of trachea in respiratory system, this is going to be the trachea that we are having, right? You can appreciate the spinous process on the back, right? This is going to be your right atrium, this is going to be left atrium. This particular angle is known as costocardiac angle beta, and this particular angle is known as costophrenic angle. This is going to be costophrenic angle. This is going to be what? Costocardiac angle. This is going to be what? Costocardiac angle. Costophrenic and costocardiac angle that we are having, right? Another thing you need to understand, these are the shadows that you can appreciate are the shadows of the breast, and this particular thing that you can appreciate, this is nothing but the shadow of the scapula that we are having. No need to worry about that. This is going to be the shadow of the scapula, right? This is a basic diagram that we are having. Now you can also appreciate this. This is going to be which border of the heart beta? This is going to be right atrium. This is going to be right atrium. This part is going to be responsible for the left ventricle beta, left ventricle. Here you will be having the aortic arch. You can appreciate this is going to be the pulmonary trunk that we are having. Somewhat here is going to be the hilum, right? Pulmonary trunk. Here you will be having the left main bronchus. Left atrium is going to be there, left ventricle is going to be there. This is the left atrium, this is the left ventricle, this is the right atrium beta, right atrium. Right ventricle is on the posterior side, right ventricle is on the posterior side, okay, posterior side. These are the oblique fissure that we are having, right? These are the oblique fissure that we are having. This is going to be your horizontal fissure, this is going to be your horizontal fissure that we are having, right? This is going to be your manubrium, this is going to be your superior vena cava. This is important, superior vena cava. This is going to be aortic arch that we are having, pulmonary trunk that we are having. This is going to be right atrium, this is going to be left ventricle, left atrium. These are the things we are having, right? So this is the basic thing we are having. This angle is going to be your costophrenic angle, this is going to be your costocardiac angle. And can you appreciate here somewhat here this particular part you will be having what? Inferior vena cava also, right? This inferior vena cava is going to come from here. This is going to draining into right atrium. So this is going to be the part for the inferior vena cava, inferior vena cava. This is going to be your superior vena cava. Both of them are draining into right atrium. Then you have got on the posterior surface you will be having right ventricle. This is going to be left atrium, this is going to be the left atrium part, and this is going to be the left ventricle bigger part, right? So this is the basic anatomy of the like you can appreciate the anatomy of the heart that we are having. What is this coarctation of aorta? Whenever you are having the constriction of aorta, you will be finding this particular sign. This is going to be 3 sign. You can also call it what? Reverse 3 sign. You can also call it what? Reverse 3 sign beta, reverse 3 sign, right? Here you will be having this rib notching. Can you appreciate this rib notching that we are having, right? This rib notching that we are having, this is the rib notching that we are having in the cases of coarctation of aorta beta, coarctation of aorta. Then we have got this particular sign. This sign is known as money bag appearance or leather bottle sign, right? You can appreciate this leather bottle or money bag appearance, right? This is something you will be finding in the pericardial effusion. So you will be having a cavity outside the heart. This is known as pericardium, right? And when you have fluid accumulation into that cavity, this is known as what? Pericardial effusion. So what is happening in this particular case? You can appreciate in this particular case, you will be having this heart borders are going to be there, right? And then you will be having what? Accumulation of fluid over this particular area in the pericardium. This is going to be what? Pericardial effusion, beta. Pericardial effusion. This thing you can easily appreciate. This is going to be what? Boot shape appearance. This is what is you will be finding in the tetralogy of Fallot, right? Heart shape or boot shape heart is going to be feature of what? Tetralogy of Fallot, beta. Tetralogy of Fallot, right? Here you will be having this particular egg on string appearance will be there. Egg on string appearance is going to be seen in the cases of transposition of great arteries, right? This is going to be TGA. This is your box shape heart that we are having. This is your box shape heart seen in the Epstein anomaly, beta. Epstein anomaly will be having box shape heart. This is going to be your figure of 8 like heart. This is going to be your figure of 8 appearance that you will be finding. It is going to be seen in the supracardiac TAPVC. Okay, supracardiac TAPVC, you can have the snowman like appearance. The snowman like appearance or figure of 8 appearance will be there, right? This is going to be what? Supracardiac TAPVC, right? On USG you cannot identify what is right, what is left, and it is going to be dependent on the patient. Otherwise all the images that you can appreciate is going to be right here, left here. Okay, this is how we can understand. So in this USG of the heart, you have got what? Right ventricle, you have got what? Left ventricle. Here you will be having left atrium, you will be having certain valves, right? You will be having these valves. These are going to be your aortic valve, you have got mitral valve, you have got this pericardium, right? This fluid will be appearing what? Fluid will be appearing black, है and what you are going to do in the ultrasound, you are going to take this ultrasound in the M mode, and we can identify this USG of heart. This is going to be known as what? Somewhat you can also call it 2D echo. Okay, 2D echo is what? 2D echo you are going to do is the echocardiography, right? Echocardiography is what you are going to use this particular instrument that is going to be based on the sonography principle only, that is going to be ultrasound principle, right? 2D echo. And you can appreciate the blood is going to be flowing, so you can appreciate the blood is going to be black in color. This is going to be hypoechoic or anechoic, whereas another pathologies, if there are going to be any calcification or something, is going to appear what? White. So you can easily identify. The next important system that we have got is going to be your musculoskeletal system, beta. Musculoskeletal system, right? In musculoskeletal system, we will discuss about the osteoarthritis. Osteoarthritis is something which is going to happen. Remember, here you will be having reduction in the joint spaces. Normally there should be some joint space, right? But here there is reduction in the joint spaces. This is known as osteoarthritis, generally seen in the older patients and seen in the larger joints, beta. We will advise our patient not to sit on small, like on the ground, right? We will give some basic advice, we give some treatment to the patient, right? The best treatment that we can offer is total knee replacement, TKR, that we can offer here, right? We can have DIP, we can have PIP involvement. This is going to be your Haberden and Bouchard notes that we are having. Haberden notes and Bouchard note that we are having, and the DIP and PIP, right? Then we have got this rheumatoid arthritis. This is going to be a disease which is going to be characterized by morning stiffness in the small joints. You will be having morning stiffness in the small joints. The most common joint that is going to be involved is going to be PIP or MCP. You can have swan neck deformity, you can have Bottonier's deformity over here, right? You can have Bottonier's and swan neck deformity. This is your normal hand. Remember, here you will be having what? Involvement of the joints, right? Bone erosion will be there, and these joints are going to be small joints. They will be having morning stiffness, and this morning stiffness is going to get cured as the day passes. With time, you are going to have betterment in the relief will be there in the symptoms, right? For the treatment of the rheumatoid, we are going to give the drugs. These drugs are known as what, beta? They are known as DMARDs. DMARDs or SARDs. They are known as disease modifying anti-rheumatic drugs, or SARDs, slow acting anti-rheumatoid drugs that we are having, right? We can have conventional, we can use biological, that you will be studying, right? Then we have got psoriatic arthritis, where you will be finding very, very characteristic penicillin cup deformity, beta. Pencil in cup deformity that you are going to have, this is going to be your pencil in cup deformity, right? You can have joint erosions, you can have this particular thing, this is known as psoriatic arthritis. Psoriatic arthritis, you can appreciate this is going to be your gout, which is going to involve this first MTP joint. First MTP joint is going to be involved. It is going to increase serum uric acid levels will be more, right? You will be having crystals, and these crystals are made up of monosodium urate. These are going to be needle shaped crystals which are going to be negatively birefringent, right? Very, very important. This patient is going to be a middle-aged patient with the symptoms of this particular things, right? You will be having pain. Acute gout will be having pain in the greater toe, right? You will be having first MTP involvement with the pain, right? Along with the erosion you will be having because of excess of uric acid deposition. And remember, this uric acid is the end product of not you can say it is the end product of nucleic acid. What is the nucleic acid which is going to make this uric acid is going to be what? Xanthine. Xanthine is going to make what? Uric acid. Xanthine is responsible for the formation of uric acid. So we can also use xanthine oxidase inhibitors like allopurinol, febuxostat, exostat, febuxostat, right? So these are the drugs that you can use. Then we have got the greater trochanter problem. This is going to be the, can you appreciate, there will be some blackness over here in the greater trochanter. This is known as what, beta? This is known as chondroblastoma. Generally seen in the children, beta. This is going to be seen at the age of 10 to 15 years. You will be finding this blackening over here on the x-ray. This is going to be the radiolucent area on the epiphysis. This is going to involve what? Greater trochanter. This is going to be known as chondroblastoma. Chondroblastoma. This is going to be epiphyseal tumor. Remember, epiphyseal tumors are going to be this important one, right? Second one, we have got the tumor which is going to be very, very important. The tumor which is going to go to the joints. This is your giant cell tumor, nothing else but your giant cell tumor, which is going to go to the distal radius. It can involve the joints also. Tumor of to the joints, generally seen in the adult patient. And here you will be having this type of soap bubble appearance. Soap bubble appearance will be there. Okay, soap bubble appearance. Then we have got this metaphyseal tumor, which is also looking like the same one, right? This metaphyseal tumor that we are having, it is tumor you will be finding in the children. This is known as aneurysmal bone cyst, beta. Aneurysmal bone cyst. Here also you will be having this soap bubble appearance. Remember, soap bubble appearance reaching to the joints is going to be nothing else but your giant cell tumor, right? If this soap bubble appearance you are finding till this particular part, this is going to be your metaphyseal tumor that we are having. Okay. The next one we have got is the fallen leaf sign or fidget sign. Can you appreciate this sign? This is known as fallen leaf sign or fidget sign, seen in the metaphysis. This is going to be suggestive of simple bone cyst, SBC, simple bone cyst. And aneurysmal bone cyst, you will be having what? Soap bubble appearance. Here you will be having simple bone cyst, beta. Then you will be having this adamentinoma. Adamentinoma is going to be the generally seen in the tibia, beta. This is going to be a diphyseal lesion. Diphyseal lesion seen on the tibia. This is going to be your adamentinoma. 20 to 40 years of age, right? Here you can appreciate this type of deformity. This type of deformity is known as what? This type of banding that you are finding is known as shepherd cook deformity. Shepherd cook, those people who are doing what? Those people who are the shepherds, right? So you can have this. They are going to have a they are going to have this type of stick, right? So this is going to be known as shepherd cook deformity, right? You will be having this type of deformity. Where do you find this? You will be finding this in the fibrous dysplasia. You can appreciate this particular one is going to have this ground glass opacities will be there. This ground glass opacities is very, very characteristic of this fibrous dysplasia. Fibrous dysplasia, also known as shepherd crook deformity. Then we have got this enchondroma, beta. This is going to be the enchondroma that we are having. It is going to be the most common hand tumor that we are having. Most common cancer of hand is going to be squamous cell carcinoma. This is the most common hand tumor we are having. This is known as enchondroma. This is going to be benign thing seen in the young adults, and this is going to be radiolucent thing with the calcification. You can appreciate this is going to be what? Radiolucency. Some blackening will be there along with that calcification on the borders. This is going to be what? This is going to be what? This is going to be your enchondroma. If you have multiple enchondroma, this is known as what? Olier's disease. This disease is known as Olier's disease. And if you have multiple enchondromas along with the soft tissue hemangioma, this syndrome is considered as Maffucci syndrome. Maffucci syndrome. Then this syndrome is considered as Maffucci syndrome beta. Okay. Then we have got this outgrowth, bony outgrowth. This is known as osteochondroma. Bony outgrowth is known as osteochondromas, right? Small bony outgrowths are going to be what? They are known as osteophytes, right? But this is not a osteophyte. This is what? This is going to be your osteochondroma. Exostosis, you can call it uh, you will be having there will be a bony outgrowth which is going to come out, that can be felt from outside as well. This is going to be abnormal growth of growth plate will grow away from the joint. This is going to be what? Osteochondroma beta. Osteochondroma. Okay. Then we have got cancerous tumors. What are those cancerous tumors? The first one that we are having is going to be having this particular appearance, sunburst appearance. Sunburst appearance will be there, and this sunburst appearance or Codman triangle will be a feature of this Codman triangle, and sunburst appearance is a feature of osteosarcoma. Osteosarcoma is the most common tumor that you will be finding in first to second decade in the children. And remember, this is going to be a tumor of metaphysis. This is going to be a tumor of metaphysis. Treatment will be what? You can give for chemotherapy. Along with this, you can go for neoadjuvant therapy, and you can also do what? Surgery in this particular case. Second most common tumor that we are having is going to be your Ewing sarcoma, which is going to have this onion peel appearance will be there. Onion peel, onion appearance will be there, and here you will be having some kind of periosteal reaction. What is periosteum? This outer layer of the bone is considered as periosteum. Pericarditis, pericardium, right? Like that we have got what? Periosteum. This is going to be seen in the children in the first decade. It is the most common primary malignant tumor of flat bones. Most common primary malignant tumor of the flat bones that we are having. Treatment is going to be same. You can give chemotherapy, you can give surgery, you can give radiotherapy here, right? The next tumor we are having beta is going to be your chondrosarcoma. Chondrosarcoma is generally seen in the older patient. This is going to be seen in the older patient, right? And here you can do nothing, but you need to go for what? Wide surgical excision. You need to curate the area, you need to cut the area, you need to take the margins also. This is going to be the thing we can do. Most common joint involved is going to be your hip joint, and here you will be having positive calcification. Calcification is going to be there, right? Some head problems we are having. This is going to be your salt and pepper skull. Salt and pepper skull. This is going to be your salt and pepper skull. This is seen in the cases of hyperparathyroidism. What is the scan you can do? This is going to be technetium 99 system EB scan that you can do here. This is your crew cut appearance that we are having. This crew cut appearance you will be finding in the cases of thalassemia beta. Salt and pepper skull in the cases of hyperparathyroidism. Hyperparathyroid means functioning of parathyroid will be increased, right? Then you will be having this eosinophilic granuloma beta. This is going to be bewailing of the skull. You will be finding this particular single lesion that you are having. This is going to be your eosinophilic granuloma. Okay. Then you have got multiple lytic lesions. Multiple lytic lesions are suggestive of what? These multiple lytic lesions are suggestive of multiple myeloma. Okay, here you will be having some proteins. Which proteins are going to be positive? This is going to be your Benz-Jones proteins are going to be positive. This is seen in the elderly patient beta. Elderly patient, multiple myeloma, very, very important, right? Then you have got this cotton wool skull. This is going to have this cotton wool like appearance. This is going to be due to abnormal bone remodeling. Abnormal bone remodeling. This is known as cotton wool skull, seen in which disease? Paget disease. Seen in which disease beta? This is going to be your Paget disease. Paget disease, right? What happens? What else can happen in the Paget disease? You will be having this type of vertebra. This is known as ivory vertebra, also known as you will be having this type of white vertebra that you can appreciate is seen in the cases of Paget disease. This patient will be having increasing in the size of the head. You will be having this increasing in the head size will be there. Increasing in the head size will be there. They can have what? This type of fracture. This is known as banana fracture beta. Banana fracture. You will be having involvement of the spine. You will be having involvement of this spine in secondary parathyroidism. This is going to be known as rugger jersey spine beta. This is known as rugger jersey spine, which is characteristic feature you will be finding with the secondary parathyroidism. Okay, what shape of vertebra you can appreciate over here? This is going to be what? This is going to be H-shaped vertebra. H-shaped vertebra is going to be seen in the cases of sickle cell anemia beta. Sickle cell anemia, you will be having this H-shaped vertebra. Okay, and this bullet-shaped vertebra, bullet-shaped virus is going to be which virus? Bullet-shaped vertebra you will be finding in the cases of achondroplasia. Achondroplasia also have what? Champagne glass pelvis. You will be having champagne glass pelvis will be there. You will be having this type of pelvis. You will be having champagne glass pelvis will be there. You will be having trident hand, right? You will be having trident hand. Okay, trident hand, champagne glass pelvis, bullet-shaped vertebra. Then this is going to be winking owl sign. This is going to be winking owl sign that you will be finding in the metastasis. This is known as winking owl sign beta. This is happening due to damage to one of the pedicles, right? You can appreciate both the pedicles are normal here, both the pedicles are normal. This is appearing as owl, right? But can you appreciate this pedicle is gone? This pedicle is gone, right? So this is going to give you winking owl sign. This is going to be blind vertebra seen in the cases of metastasis beta. Metastasis, you will be finding this thing. Then we have got TB. TB is going to have better paradiscal involvement. Two discs are going to be involved, superior and inferior one. So you will be having paradiscal involvement. Complication is going to be abscess formation. Then we have got codfish vertebra. This is your codfish vertebra that we are having. Codfish like vertebra that we are having. So this is going to be fish mouth vertebra that you can have over here, right? Then we have got osteomyelitis beta. Osteomyelitis is the most common bone infection that you can have because of this particular Staph aureus. Okay, this bone infection is because of what? Staph aureus. You can have dead bone. This is known as dead bone is known as sequestrum, right? You can have involucrum. This is going to be the due to reactive sclerosis, and you can have cloacae formation, which is going to responsible for the sinus formation will be there, which is going to release what? You will be having what? Discharge from this particular sinus, right? This spine is known as bamboo spine or dagger sign that you will be finding. A bamboo spine and dagger sign is very consistent with the ankylosing spondylosis beta. Ankylosing spondylosis generally happening in the young patient. Okay, this is going to be your bamboo spine or dagger sign that we are having. In the cases of osteoporosis, you can check for this osteoporosis. We can check for investigation of choice. This is going to be your DEXA scan beta. DEXA scan is going to be investigation of choice. This is going to be dual energy X-ray absorptiometry test. T score is going to be there. This is going to be less than 2.5. T score less than 2.5 is suggestive of what? Osteoporosis. 1 to minus 2.5 is going to be suggestive of osteopenia. That means decrease in the bone density, and normal bone is going to be 0 to 1. Normal is going to be 0 to 1. This is going to be osteopenia. This is going to be osteoporosis, right? And the drug of choice for osteoporosis is going to be your bisphosphonate beta. Bisphosphonates are the drug of choice for osteoporosis, right? Then we have got a respiratory system where you will be having the normal anatomy. Let's understand the normal anatomy. This is going to be trachea beta. This is going to be the apex part, upper part, middle zone, lower zone. These are the zones that you can appreciate normally. Now you can understand this is going to be right atrium, this is going to be left ventricle. Here somewhat you will be having inferior vena cava. This is the part where you will be having superior vena cava. This is the part for the right atrium. So this is the part for the right ventricle. This is the part for the right ventricle. Yes or no? No beta. This is going to be what? Left atrium. This is going to be left ventricle. Left ventricle, है ना? This is going to be left ventricle. This is going to be left atrium. Here you will be having somewhat right atrium will be there, and the right ventricle is going to be on the posterior surface, right? This is going to be the angle that you will be having, costocardiac angle, right? Here you will be having angle. This is known as costophrenic angle. This is going to be costophrenic angle. In the midline you will be having this trachea. You will be having somewhat aortic knuckle over here. right? These are the basic things that you should be understanding. Okay, we can differentiate our lobes on the basis of this silhouette. This silhouette we have discussed in the full classes, right? This is going to be the silhouette that we are having. Right lower lobe, left lower lobe, how we are going to divide them on the basis of different structures we have seen here, right? Then we have got the collapse of the lung. Whenever you are going to have lung collapse, what is going to happen, beta? This trachea is going to deviate to ipsilateral side. Okay, the trachea is going to deviate to ipsilateral side. Can you appreciate this tracheal deviation to the same side? This is going to be what? This is going to be happening because of the lung collapse. So anytime you have this lung collapse, you will be having what? Ipsilateral side collapse of the trachea, right? You can have this thing in the cases of atelectasis, where you will be having lung collapse, right? Lung collapse is going to cause what? Deviation of the trachea on the same side, beta, same side. Okay, when you will be having opposite side deviation of the trachea, you can appreciate this trachea is deviated to the opposite side. Here there is a problem. Normally air should be there, air will be appearing black, right? Here there is a problem. Now the trachea is shifted to the opposite side. This is going to be seen in the massive pleural effusion. Because of pleural effusion means what? You will be having a cavity. This cavity is known as pleural cavity. This is going to be your lungs, and outside lungs you will be having what? Pleura. And when you have accumulation of fluid in the pleural cavity, this is known as pleural effusion, beta. This is known as pleural effusion. So we can have massive pleural effusion over here, and this massive pleural effusion is going to cause what? It is going to cause deviation of the trachea on the another side. Okay, deviation of trachea on the opposite side. Contralateral deviation is going to suggestive of pleural effusion, pleural mass, pleural effusion and pleural mass. Okay, when the trachea is pulled to the same side, that means what is happening? It can be due to lung, it can be due to lung collapse, it can be due to atelectasis, right? There will be atelectasis of the lungs, there can be collapse of the lungs on the same side. You will be having tracheal deviation on the same side. But trachea is very important. You see at the you look at the trachea, you will understand. If trachea is going to the same side, that means lung collapse is there. If trachea is going to the opposite side, that means what can be pathology? It can be due to pleural mass, it can be due to pleural effusion, right? Then we have got the pneumothorax. Pneumo means air, thorax means you will be having air in the lungs, right? You will be having lots and lots of airs. Normally you should be having this type of bronchovascular markings, but can you appreciate there is loss of bronchovascular markings? You cannot appreciate these bronchovascular markings, or you can see decrease in the bronchovascular markings is suggestive of what? Air in the right side of the lungs. There will be more air in the right side of the lungs. The investigation of choice is going to be what? NCCT. We can do non-contrast CT scan, and the treatment you can do what? You can insert the ICD tube. You can insert the ICD tube. What is the side? That is going to be fifth intercostal space, mid axillary line, fifth intercostal space you can enter, or you can also do needle decompression, where you will be going on the second intercostal space, mid clavicular line, second intercostal space, mid clavicular line. This is going to be the case of pneumothorax, air in the lungs, more air in the lungs, right? Then you will find this this is a normal lung. You will be finding this costophrenic angle normally, right? But can you appreciate there will be loss of this costophrenic angle? There will be some flattening of the diaphragm also. You can appreciate normally this diaphragm should not be like this. Diaphragm should be like this. This is the normal diaphragm, right? But this is the normal diaphragm that we are having, right? But can you appreciate here there is a flattening of the diaphragm also? So this is suggestive of hyperinflated lungs. You can appreciate the spaces between these two is also increased, right? This is a hyperinflated lungs that you will be finding in the cases of COPD or asthma. COPD or asthma, here you will be having more black appearance of the lungs, beta, more black appearance of the lungs. Then we have got what? Pleural effusion. In pleural effusion, you will be having this accumulation of fluid over here, and this is going to be the investigation of choice is going to be the ultrasound bit. Ultrasound, you will be finding this white color opacity. This is going to be what? This is going to be nothing but the fluid over here, and this is going to be pleural effusion. Okay, you can also identify this fluid with the help of ultrasound also, right? Investigation of choice is going to be ultrasound. What else you will be finding? You will be finding the blunting of the CP angle. Even if some amount of fluid is there, you will be finding what? Blunting. You will be finding what? Blunting of the CP angle, because this is due to gravity, right? Every fluid is going to come over there into because of gravity, so you will be having loss of this blunting, right? Then we have got this air fluid level in the hydropneumothorax. Hydropneumothorax, hydro means water. Pneumo means air. So you will be having this hydropneumothorax. You will be having what? You will be having air fluid level will be there. Okay, this can be seen in the cases of trauma. Treatment is going to be ICD insertion with underwater seal. ICD you are going to insert with underwater seal beta. Okay, you can have consolidation of the right lower lobe over here. This is going to be right lower lobe consolidation. This is seen with the lobar pneumonia. Lobar pneumonia beta. Lobar pneumonia is going to involve a single lobe. A single lobe involvement will be there. Whereas in the atypical pneumonia, you will be having what? You can have viral pneumonia where the fluid will be in the interstitial space, right? You can have pneumonia due to COVID-19. This is going to be atypical pneumonia. Okay, in atypical pneumonia, the drug of choice is going to be azithromycin, right? Whereas in the cases of typical pneumonia, lobar pneumonia, it is what is the most common cause? This is going to be streptococcus pneumonia. What is the most common cause for atypical pneumonia is going to be what? Mycoplasma. Mycoplasma. Here the most common cause is going to be streptococcus pneumonia, right? Atypical pneumonia is also known as walking pneumonia beta because the patient is going to have less of a symptoms and more of a disease. Here you will be having more of a disease. Here you will be having less of a disease and more of a symptom. More symptoms, less disease. This patient will be admitted early. This patient will be treated early. This patient will be having less symptoms and more disease. This patient is admitted late, and this patient has a high risk atypical pneumonia. Then we have got this lung abscess beta. In lung abscess we have got what? In this got what? In the cases of lung abscess, you can appreciate this is a lung abscess. We have got thick walled cavity over here, and air fluid level is also going to be positive. This is a lung abscess. Okay, and if you are having some pre-existing cavity, and in that particular pre-existing cavity because of secondary TB, what is going to happen? You will be having what? You will be having another things, right? You will be having other things like aspergilloma can also happen, right? You can have what? Aspergilloma. In the pre-existing cavity you will be having what? Fungal balls accumulation, and this is something like a fungal ball, right? Then you have got this miliary TB beta, which is a TB of the systemic circulation. That means you are having what now? Bacteremia, bacteria in the blood. Emia means in the blood, so you will be having this bacteria in the blood. This is bacteremia seen in the cases of miliary TB beta, miliary TB. In the acute respiratory distress syndrome, why it is appearing white, why it is appearing radio opaque? The reason is pretty simple. You will be having what? Fluid over there, right? Instead of air you will be having lots and lots of fluid over there, and this fluid is going to give you this black color. Instead of black you will be having white color appearance. That is the opacities, multiple opacities you can find. This is going to be the ARDS. You need to identify the cause, you need to treat the cause here, right? We can have pneumoconiosis like silicosis. We can have silicosis. Very important thing is going to be what? Yeah, whenever you see this egg cell calcification, you will be finding egg cell calcification. You will be having hilar lymphadenopathy. You will be having, this is going to be suggestive of what? This is going to be suggestive of silicosis. Asbestosis can have cancers. It can convert into cancers also. What is the cancer it is associated with? It is associated with a special cancer. This is known as mesothelioma, right? Most specific is going to be what? Mesothelioma. You can have adenocarcinoma also. In this cold workers, they are going to involve what? Upper lobes, progressive massive fibrosis with small nodular opacities in the upper lung field, generally involving upper lobes, cold workers. This is going to be your berylliosis. Diffuse infiltrates will be there in the cases of berylliosis beta. In sarcoidosis also you will be having this type of adenopathy. This is going to be your bilateral hilar lymphadenopathy will be there, right? This is your normal x-ray. This is the x-ray of hilar lymphadenopathy. On gallium scan you will be finding what? Garland sign, lambda sign, and hilar lymphadenopathy will be there in the cases of sarcoidosis beta, sarcoidosis. Then we have got CNS. In the CNS we have got what? We have got this particular thing. This is going to be genu. This is going to be your anterior limb, posterior limb. This is going to be your internal capsule that we are having, right? The same thing you can appreciate. This is your lateral ventricles that we are having. This is going to be your third ventricle. Here you will be having cisterns will be present, right? This is going to be the basic thing we are having. You can appreciate here, this is going to be your corpus callosum, your frontal lobe, right? You can appreciate this corpus callosum. Here you will be having structure. This is going to be thalamus. Below the thalamus you will be having what? Hypothalamus. And below hypothalamus somewhere you will be having what? You will be having pituitary gland. This is going to be the thalamus. You can appreciate over here, this is going to be thalamus. You will be having hypothalamus, and then below hypothalamus somewhere you will be having what? In the sella you will be having pituitary gland. Here you will be having pituitary. This is going to be what? Hypothalamus. This is going to be midbrain. This is going to be pons and medulla. Midbrain, pons and medulla will be there, right? Medulla will be there. This is going to be your fourth ventricle. This particular part is going to be fourth ventricle. This is your cerebellum that we are having. Okay, these are the frontal lobe, parietal lobe, occipital lobe, and these are the sinuses. These hollow cavities that you can appreciate, these are the sinuses we are having, paranasal sinuses. We have got sphenoid sinus, we have got frontal sinus over here, right? This thing is this is the view, very important. Then we have got what? These are the frontal horns. Then we will be having what? Capsule will be there. This is going to be caudate nucleus. This is going to be what? This is going to be your sylvian fissure. This type of area is known as what? Sylvian fissure beta. Here you will be having what? Thalamus. Thalamus is going to be there here, right? And you will be having what? You will be having caudate nucleus, and below this caudate nucleus and internal capsule you will be having what? Putamen and globus pallidus. Okay, so you will be having this nucleus. This is your caudate nucleus. Look again, this is going to be your frontal horns. These are going to be the ventricles. Below the ventricles you will be finding what? Caudate nucleus. And here you will be having this particular structure. This is going to be what? This is going to be your internal capsules. In front of the internal capsule you have got what? Globus pallidus and putamen. Putamen and globus pallidus is going to be there, and this particular area is going to be what? This is the area for thalamus beta, thalamus, right? Here you will be having this occipital horns. This is going to be your posterior lobe. That is going to be your occipital lobe that we are having, right? This is going to be temporal lobe. This is going to be frontal lobe in the front part, right? For any time we can have what? Trauma. In the cases of trauma we are going to have what? We are going to have the, what are the features you will be having? We can have intracranial hemorrhages, right? We can have intracerebral hemorrhages, right? So what are the ICH we are going to have? We can have EDH, we can have STH, we can have SAH. EDH is epidural hematoma. Epidural hematoma, what is the artery that is going to be involved? Remember, all of them are going to be the arterial hemorrhage. The only one which is going to be the venous hemorrhage is going to be the STH. STH is going to have what? Emissary bridging veins are going to be involved, right? So first one we are discussing is the EDH, which is going to have most important site is going to be pterion, and it is going to involve the temporal lobe, and it is going to have middle meningeal artery involvement. On appearance on NCCT will be finding what? Lemon or biconvex opacities will be there, right? Special point you need to understand, you will be having what? Lucid interval over here. The site will be pterion, and you need to drain it. You need to drain it with the help of burr hole surgery. You need to do the surgery. What is the name of the surgery we can do? This is burr hole surgery that we are going to do. You will be having this lemon shape opacity beta, lemon shape opacity. Second is your STH. STH is going to be because of emissary veins. You are going to have banana or crescent shape. You can appreciate the banana or crescent shape over here. This is going to be the banana or crescent shape over here. This is the only venous hemorrhage that we are having, right? Only venous hemorrhage, and the drug will be mannitol beta. Mannitol you can give. Third one is your subarachnoid hemorrhage, which is going to be ruptured in the berry aneurysm. It is the most important, worst headache of my life beta. Worst headache of my life. Or thunderclap headache. Thunderclap headache, worst headache of my life. You will be having blood in the sylvian fissure. You can appreciate the blood in the sylvian fissure. And lastly, the drug of choice is going to be what? Nimodipine here. Nimodipine. And lastly, we have got intracerebral hemorrhage, where you will be having involvement of the lenticulostriate artery, Charcot artery. Here you will be finding the midline shift. You can appreciate the midline shift of the ventricles. You can appreciate the midline shift of the ventricles, and this site, the most common site of bleeding in this particular case is going to be what? This is the most important and most common site. This is going to be what beta? This is going to be putamen beta. This is going to be your putamen. Putamen is the most important and most common site of hypertensive bleed. Here you will be finding what? Midline shift will be there. Okay, intracranial space occupying lesion will be there, and the most important site for this particular one is going to be your putamen. The drug of choice for this particular one is going to be nicardipine beta. क्या दवाई दोगे? Nicardipine देंगे. Then you can appreciate in the next one we have got, this is going to be your corpus callosum, and on the corpus callosum you can appreciate this finger like projections. These finger like projections are known as Dawson finger. क्या बोलेंगे इनको? Dawson fingers. And investigation of choice for this particular one is going to be MRI again. We can do MRI. This is going to be your multiple sclerosis that we are having, which is a demyelinating disorder that we are having. Important one, what is the criteria that we are going to follow here? This is going to be your McDonald's criteria beta. McDonald's criteria is the criteria that we are going to follow. This particular appearance is the appearance of neurocysticercosis, where you will be having the starry sky appearance, where you will be having this involvement of this tinea solium will be there. This is due to tinea solium involvement. And the MRI is going to be the investigation of choice. You can also do what? CT scan, and the drug of choice is going to be what beta? Albendazole is the drug of choice in this particular case, right? Then you can appreciate this pseudocyst over here. Can you appreciate this pseudocyst in the brain? You will be having gelatinous pseudocyst in the basal ganglia. This is suggestive of cryptococcal meningitis, which is the most common cause of meningitis in HIV positive patient. Then we have got what? Toxoplasmosis beta. This is going to be due to toxoplasmosis. Ring enhancing lesions are seen in toxoplasmosis. Toxoplasmosis you will be finding with the cats beta. Cats are going to be the definitive host that we are having. This face of panda sign you will be finding in the Wilson disease. This face of panda is something which you will be finding in the Wilson disease. Wilson disease is due to mutation in ATP7B gene. ATP7B gene. ATP7A is going to cause what? That is going to be Menkes disease. This is your neurofibromatosis type 2 NF2. This is your neurofibromatosis type 2. This is going to have bilateral schwannoma, acoustic schwannoma. This is the most common cerebropontine angle tumor beta. Most common cerebropontine angle tumor. This is going to be your bilateral acoustic schwannoma. This is going to be your meningioma, and this meningioma will be having this dural tail sign. This dural tail sign is going to be suggestive of what? Meningioma. Meningioma is going to be suggestive of dural tail sign beta. Dural tail sign. Then we have a tumor which is going to cross the midline. The tumor which is going to cross the midline is going to be what? This is going to be your glioblastoma multiforme beta. Glioblastoma multiforme, which is also known as butterfly tumor. This is also known as butterfly tumor, butterfly glioma. Okay. And lastly, we have got this particular one. This is going to be your oligodendroglioma. Oligodendroglioma involving your frontal lobe beta. Frontal lobe involvement will be there, and this is going to have calcified lesions will be there. Oligodendroglioma. Here you will be having what? Fried egg appearance. This is going to have what? Fried egg appearance. Fried egg appearance. Oligodendroglioma. IDH1, IDH2. This is going to be oligodendroglioma. Then we have got some ENT slides. Can you appreciate this fried egg appearance? You are also finding in two other diseases. This fried egg you will be finding, we have discussed in microbiology, where we have discussed in fried egg appearance. We have discussed in the bacteriology. This is going to be mycoplasma. Remember, this mycoplasma is also going to show you fried egg appearance on papilla agar, right? Another one we have discussed is about the pityriasis versicolor beta. Pityriasis versicolor. Okay, in pityriasis versicolor, when you are going to put this particular thing in as the SDA agar, you will be finding what? Fried egg colonies. Fried egg colonies. Fried egg colonies. Fried egg things will be here. Then we have got the CNT. Can you appreciate? This is the maxillary sinus that we are having. Maxillary sinus. These are going to be your ethmoidus, middle turbinate. We have got maxillary antrum. We have got this is the small part is going to be nasal septum. This is going to be your inferior turbinate that we are having, right? We have got this is going to be right halar cells. The superficial and outermost cell is going to be agar cell. We have got agar cell. This is going to be your left agar and this is going to be your sphenoid sinus. Will be having what? Mucocele formation of right onody cells. Okay. So we can have certain views. What are the views we are having? We have got Waters view for maxillary sinus, and we have got it for orbital floor fracture. We can do this view. This is going to be the Waters view beta, Waters view. Then we have got Caldwell view. Caldwell view you are going to use for the frontal sinus and superior orbital fissure. You are going to use this Caldwell view for superior orbital fissure and frontal sinus. Then we have got Pierre's view. This is going to be the open mouth X-ray you are going to do for sphenoid sinus. These three are important ones. These three are important ones. Okay, we have got Waters, we have got Caldwell, we have got Pierre's view. Then you have got some important sign. These are going to be the two important sign that we are having. The first one is going to be your thumb sign. Thumb sign you will be finding in the cases of epiglottitis beta. Thumb sign is something you will be finding in the cases of epiglottitis, where you will be having this thumb sign. This is the thumb sign you will be having in the cases of epiglottitis, and this epiglottitis is due to Streptococcus pneumonia. In the exam you will be marking this as the first option, then Haemophilus influenza B, then Haemophilus influenza. Since we have got vaccination for Haemophilus influenza B, this thumb sign is more commonly seen with what? Streptococcus pneumonia. Whereas the steeple sign you will be finding with the para-influenza virus. Para-influenza beta. Para-influenza virus is going to have this steeple sign. This steeple sign, it is going to cause what? Croup. It is going to cause what? Croup or ALTB. ALTB you can have, laryngotracheobronchitis. This is going to be your para-influenza virus. Then we need to look for the foreign body beta. If you are going to see the X-ray, in the X-ray, this particular thing, anytime, remember one thing, foreign body, anytime the investigation of choice is going to be what you are going to do. What first thing is going to be X-ray. What you are never going to do, what is contraindicated, is going to be your MRI, because it can be metal and metal can kill you, right? If it is a metal, it can kill you. So this is going to be the thing. If it is like you are having vocal cords, and these vocal cords are going to be what? These are going to be lateral structures. So here what is going to happen, if the stone is in the if this coin is in the vocal cord, what would be happening? This would be appearing like that. If this coin is going to be on the vocal cord, it would be appearing laterally on the AP or PA view, right? So in the AP or PA view, if the coin is there and it is appearing lateral, if it is appearing laterally like here, this is suggestive of the what? It is in the trachea. It is in the trachea or it is in the vocal cord. But if the coin is appearing, if the coin is appearing in the AP view, this coin is appearing round. This coin is appearing round in the AP or PA view. It is suggestive of the coin is where? The coin is in the esophagus beta. Esophagus, right? The coin is in the esophagus, and if there is a coin is in the esophagus, it can come below. The narrowest part is going to be subglottis. If it can cross the subglottis, it can easily cross your whole of the GIT, right? We need to give what? We give the bananas to this patient. We give mashed potato. This coin will be going out of the stool, right? It will be coming out in the stool. Then we have got some nuclear scans beta. What are the nuclear scans we are having? We have got some nuclear scans, like we have got for renal, we have got some scans like DMSA scan and DTPA scan. Remember, this DMSA scan is going to be for the morphology scan of the kidney. M से याद रखना, from M you can remember it is for the morphology and scarring. DMSA scan is for the morphology and scarring scan for the kidney. Whereas this DTPA scan is going to be identifying the GFR estimation, glomerular filtration rate estimation, and this MAG3 is going to estimate the overall renal function beta. These are your nuclear scans that we are having. We have got bone scan, where we are going to use what? Technetium-99 MDP. It is the investigation of choice for bilateral stress fracture also beta. Bone scan is the investigation of choice for bilateral stress fracture. Okay, for unilateral stress fracture, remember we are going to do what? MRI. For any other fracture, we are going to do what? CT. We can do what? X-ray or CT scan. But for stress fracture, you are going to do unilateral stress fracture, you are going to do what? MRI, and bilateral stress fracture, you are going to do what? Bone scan. Okay, it is also going to be done in the cases of multiple myeloma, where you will be having multiple lytic lesions. You can also do it in the cases of prostate and osteomyelitis beta. Biliary scan that we can do, this is going to be technetium-99M scan. This is going to be also known as HEDI scan. HEDI scan. For parathyroid adenoma, we can do what? System AB scan. System AB scan is very, very important. We can also do SPCET. SPCET, this is going to be what? This is going to be single photon emission computer tomography that we are having. For the pheochromocytoma, we can do what? MIBG scan or DOPA or PET scan we can also do, right? PET scan generally we are doing for the cases of identification of what? PET CT we are going to do for the identification of metastasis metastasis, where we are going to use what? Fluorodeoxyglucose we are going to use radioactive, okay, 18 FDG. Then we have got what? This thyroid scan that we are using, this is going to be iodine 123 scan that we are using. And we have also got Mickel's scan, or for Mickel's diverticulum we are going to use what? Pertectinate scan. This is also going to be technetium 99B stain. So all these nuclear scans that we are doing are going to be based on some radioisotopes, and we are going to give some radioisotopes. We are going to take the scans from certain cameras we are having, right? And this is going to be the basic funda. So all this technetium 99 scan that we are having, they are going to be the same modality of the nuclear scan, right? So we are done with this important things, whatever important things we are having in the radiology. We have just tried to cover in a very quick and concise manner. I've just tried to cover all the things that you can see just before your examinations. Okay, we have not done things on great details, but yes, we have just tried to summarize everything in short, right? So thank you so much for all the patience. Take care, guys.